Good morning, everyone. Welcome to the 11th edition of Spectrum 2022, which is a symposium on cardiovascular therapies and research update, Mangaluru. Today, we are here gathered for the 11th edition of Spectrum. We always believe that learning is a lifelong process. We learn every day, every time, irrespective of the situation. Even today, at this another pandemic juncture, we all here gathered to have to learn, share, and upgrade our knowledge. Ladies and gentlemen, once again, a warm welcome to eSpectrum 2022. To begin with, may I request Dr. Manjunath Vivi, the organizing chairman of this eSpectrum 2022, to give his welcome address and opening remarks. Over to you, sir.
Dear friends, good morning. Greetings from Mangalore. Welcome to the 11th edition of Cardio Conference Spectrum 2022. It is a symposium on cardiovascular therapies and research update, Mangalore. At the outset, I thank profusely all the delegates who have logged in and the people who have come for a physical meeting for the afternoon workshops. This Spectrum has the first edition of Spectrum started in 2012 with the able support of the management of AJ Hospital and Research Center and the AJ Institute of Medical College by our beloved chairman, Dr. AJ Shetty and the group. And we have come across almost 11th edition today. And each time, every year, the theme of Spectrum changes. So we keep changing with the amalgamations of different clinical intervention, non-intervention subjects. So each year it is made interesting because there's a different set of the topics are decided. Some time back we had a non-cardiac topics also of relevance to the cardiology. Every year that the last year also we had, because of the pandemic, it was virtual Spectrum. This year we have a hybrid form, virtual morning session and physical workshops on shockwave IVL and EP study for DM and DLB students, PGs, and in the afternoon. So we also have a physical panel discussion on lipids, which will also be aired. This year the topics are a combination of clinical cardiology and newer therapies. We have eminent national speakers and also two international speakers. One from Australia, Dr. Shetty, and another from Dr. Ldl from McMaster University, Canada. So both are eminent speakers of international standard. Dr. Shetty is the first speaker, and he is the first person to do the renal innovation in VA. And also Dr. Ldl is known for his greatest trial, which has come, the Compass 2017 trial. He is the principal investigator for the Compass trial. So we have eminent national speakers also who will deliberate on various aspects of cardiology. In the afternoon, we have physical meet, which will help the PGs, DM and DNB PGs, to know about the latest technology of interventional cardiology and electrophysiology. I hope today's program is useful and thought-provoking. On behalf of the organizing committee, myself as well as Dr. Purushottam, who is our organizing secretary, I welcome all of you for this hybrid meeting. And thank you once again for logging in as well as present here physically. Thank you so
much. Thank you, sir, for taking us through the good memory of Spectrum series, as well as briefing about today's this scientific feast, and welcoming all our faculties, delegates gathered physically as well as virtually. Before we start, I request all the virtual participants to please visit our exhibition area so that you can support our exhibitors as well. So let us start our first session of the day. To begin with, we have Dr. Sharat Shetty from Australia on the topic Renal Innovation Therapy Revisited, And to chair this session, we have with us Dr. Manjunath Bivi and Dr. Padmanabh Kamath from Mangalore. So Dr. Manjunath sir is already here, and Dr. Padmanabh sir also joined virtually. I welcome you, sir. So over to you.
Good morning, friends. Our first topic is on renal denervation, and the speaker is Dr. Basan Shetty. He is our own Mangalorean, and he is at present the consultant cardiologist at Murdoch and Perth Mount Medical Center, Australia. A lot of credits to his achievements, and particularly he has done the first renal denervation procedure for uncontrolled blood pressure in VA. He is also the first performed the first case in the world using a TIVUS ultrasound-based renal denervation system. He has got a lot of papers to his credit on the area of aging, area of cutting-edge technologies. Frequently, he speaks at national and international conferences. To begin with, I think the renal denervation is getting revisited. As you know that a few years back, probably after the Simplicity hypertension free trial, which failed to show the benefits, it was in the background for some time. And nowadays we feel that it is revisiting, and especially in Europe and the Australian continent, I think the cases are increasing. And because of the evidences which has come, especially the Radiance hypertension trial, which got ACC virtual in 2021, the FDA has approved in December 2020 the renal denervation therapy. So we are eager to hear Dr. Sharad Shetty, his views presently on renal denervation. Over to Dr. Sharad Shetty.
Good morning. It gives me great pleasure to be presenting today to Mangalore, which is essentially my hometown, although I've never really lived there. I hope everyone's well and staying safe in these times. I would like to thank the organizers for asking me to speak on renal innovation, which is what I will be elaborating on, particularly the resurgence of the therapy. Allow me to bring up my slides and share my screen in a few seconds. Okay, so renal innovation has been around for more than a decade, but it has its ups and downs, particularly in view of the evidence that was being generated around it. I live in the city of Perth, which is on the west coast of Australia, and we had been involved in this therapy since about 2010, which when it was initially introduced, a lot of the initial work for renal innovation was actually originally performed in Australia, predominantly in Melbourne. These are my disclosures, and that's one of the hospitals that I work at. So we all know that hypertension is a major health burden, and it's going to involve about 1.6 billion people in a few years' time, and has significant health-related costs because of hypertension. Currently, about 1 billion people are affected by hypertension. The problem is that a large number of them are not even detected, and the ones that are detected, a number of them for some reason don't get therapy, and even amongst the ones that do get therapy, only about 1 in 5 or so actually end up getting optimal control of blood pressure, and this is the scenario in 2019. And before we get into renal innovation, I just want to impress upon you the effect that lowering of blood pressure has on cerebrovascular and cardiovascular mortality as well as morbidity. Just a 5 to 10 millimeter drop in blood pressure causes a double-digit reduction in major stroke rates, heart failure rates, and so on. And a 10 millimeter systolic drop causes an excess of 20% reduction in major cerebrovascular and cardiovascular outcomes. So although it might seem to be a small reduction, I think we need to realize that this has a very significant long-term consequences. Moreover, patient adherence is much worse than you think. More than about 8% of people in a survey said that they would actually give up 2 years of their life to avoid taking one daily pill. And nearly 50% of patients actually get non-adherent within 1 year of initiating therapy. So renal innovation is not a new thing in one sense. It's an old paradigm that's been revisited. It was being performed surgically as early as the 1950s and 60s. Surgical splanchnosectomy and ganglionectomy was performed. And the problem was that it actually caused non-selective denervation and has significant side effects and morbidity. But one thing was for sure, it did cause a reduction in blood pressure. And not only did it do that, it actually was demonstrated to have a reduction in mortality. And this was quite early on. But obviously with the advent of modern drugs and the morbidity associated with the surgery, it was discontinued. But more recently, it was performed via the percutaneous route by a company called Artery, which was eventually acquired by Medtronic. This slide shows the journey that the therapy has been through in terms of accumulation of evidence, beginning with the Htn1 study, and we might go through some of these in a bit more detail. So the Htn1 study was a single-arm study where the therapy was performed in a group of patients, and initial blood pressure was then compared to post-procedure blood pressure. And it showed that it caused a significant reduction in blood pressure, which was sustained even out up to 3 years. The Simplicity Htn2 study was a randomized controlled trial. Patients were randomized to either have the therapy or have optimal medical therapy. And this again caused a significant drop in systolic blood pressure around the 30 millimeter mark as compared to the control group, which was basically continuing medical therapy. And this was a major study. This is the first randomized controlled trial showing that this therapy worked. And this led to a significant expansion in the therapy, with a number of companies entering the field with the expectation that renal denervation was going to become a mainstay in the therapy of resistant hypertension. The Htn2 study followed up to 3 years, showed that this blood pressure reduction was quite sustained up to the 3-year mark. Then came the Htn3 study. Now, before this therapy was approved in the US, there had to be a large US trial that had to be done. This was again going to be a randomized controlled trial. However, the randomization in this case was not going to be to optimal medical therapy, but to a sham procedure. So one group of patients received the renal denervation procedure, and the other group received a sham control trial, a sham procedure. So it was a truly double-blind randomized study. The Htn3 study did achieve a safety endpoint, as has every other trial for renal innovation. Safety has never been an issue. However, the efficacy endpoint was not met, and there was no significant drop in blood pressure at the 6-month mark between renal innovation or the sham therapy. Now, there were a lot of confounding factors and a lot of criticisms about the study in terms of the experience of the physicians performing the procedure, the method in which the procedure was performed. There were about 40% of patients had medication changes, although the trial mandated that medication needed to be kept constant. So all of these factors were given as an explanation in regards to the trial failing to meet its endpoint. However, the bottom line was that the trial showed that the therapy was not able to cause a significant drop in blood pressure. And this led to a significant loss of interest or withdrawal of the therapy as mainstay in clinical practice, at least. So this led to a point where the companies had to decide whether they had to stay in the field or exit it. And if so Medtronic made the choice of staying in it, as they believed in the therapy. And however, there was a change in the way they thought about it, and hence there was a need to again go about getting proof of principle to show that this therapy can actually lower blood pressure. So they had to go back to the drawing board. The other thing was that there was a little bit more understanding in terms of the anatomy of the renal nerves. That you must realize that prior to this therapy, there was no real need to study anatomy of the renal nerves in great depth. What they found more recently was that the renal nerves do not converge onto the renal artery until it gets distally. So the original belief was that you ablate it proximally, and that was enough to get the nerves. But the distance of the nerves from the renal arterial lumen was more proximally, and they seem to converge as they go distally. So it was now thought that it is important to ablate distally as well. And this was a change in the way the procedure was performed in the subsequent studies, as well as the therapy itself was now being performed by the spiral catheter, which is a multi-electrode catheter, and is delivered over a wire, and hence it enables delivery of the system more distally into the distal renal arteries. So the first study was the spiral Htn off-med proof of principle study, and this showed that there was a significant drop in blood pressure with the therapy as compared to the sham procedure in 24-hour blood pressure, as well as the office or clinic systolic and diastolic blood pressures. So this was a positive trial showing that in a group of patients who are either drug naive or had their drugs withdrawn at the commencement of the trial, Renal Innovation was able to drop blood pressure. And the reason to do an off-med trial was to get rid of any confounding factors, like because of the drugs and the changes in drugs. So these patients had no drugs on board, and one group having the Renal Innovation procedure and the other group having a sham procedure. So this was as clean a trial as you could have, with the patient being completely blinded to eliminate any placebo effect. So this showed proof of principle. There was also simultaneously an on-med Htn study, which did pretty much the same thing, except these patients remained on antihypertensive medications, and even in this group, there was a drop in office systolic as well as ambulatory systolic blood pressure, and it again met its primary and efficacy endpoint. So two positive proof of principle sham control trials. So this led to the next trial, which is the pivotal trial, or the trial that was meant to was for the purposes of US FDA approval. This was a large trial. Again, the FDA said that they need to perform an off-med trial, and this was similar to the off-med proof of principle study, except it was a much larger study. Again, patients were randomized to either receive Renal Innovation or the sham procedure, and they were off any medications. There were no major significant adverse events, as has been with most Renal Innovation studies. What about the efficacy? This was again able to show and meet its primary endpoint for efficacy. So this was a major trial that showed in a large group of patients that in a sham control trial that Renal Innovation can drop blood pressure and met its primary efficacy endpoint. The one thing that should be realized in how Renal Innovation is different from drugs is that Renal Innovation is always on. There is no on and off effect. It seemed to cause a more or less 24-hour drop in blood pressure. So there were no periods where people had good control and poor control, whereas throughout the 24-hour period, there seemed to be some reduction in blood pressure, which is important because that is what the target organs are actually exposed to through the day. One of the questions that gets asked is what happens to these nerves? Do they regrow? And if they regrow, can the effect of Renal Innovation go away in a few years? And this was studied in an animal study, and I'll just briefly go through it just to show how extensively this was looked at. So these are the slides showing the ablation site as well as distal to the ablation. And what happens is that at the ablation site, initially you get inflammation and necrosis, and there's atrophy distal to it. This is how most nerve fibers behave. Subsequently, with time, there is fibrosis at the site of the ablation, whereas distal to the ablation, there is complete nerve bundle atrophy. And this fibrotic response essentially renders any nerve growth highly unlikely, particularly any functional regrowth, almost impossible. Apart from these randomized controlled trials, there has been a registry which has been going on for a number of years. It's called the Global Simplicity Registry. This is a real-world registry that looks at that looked at patients that have been performed in clinical practice, and this has looked at almost 3,000 patients that have been followed up for about 3 years or so. So in the real-world setting as well, renal innovation has been shown to have significant drop in blood pressure, and this is again sustained out to the 3-year mark. And it seems to work whether you're on 3 medications, 4 medications, or 5 medications. So irrespective of how many medications you're on and how resistant you are in terms of being a resistant hypertensive, there was a drop. Renal innovation seemed to work in all of these groups. And about 55% of resistant hypertensive patients had adequate BP control without increase in medications. So this is quite significant because despite the medications remaining constant, there had been a significant number of people actually achieving optimal blood pressure control in the real world. The other thing that is evident is that renal function seems to remain stable, and this seems to be the case even in people with reduced GFR. It's important to understand that when you have uncontrolled hypertension, there is the natural history itself is that there is a loss in GFR as years go by, and these patients with renal innovation more or less had stable GFRs over the 3-year mark. So to go back to the evidence available for this therapy, we know that Htn1 was positive, Htn2 was positive, Htn3 was the negative US trial. Subsequent to that, we've had the 3 positive sham-controlled trials, including the large off-med pivotal trial. So I don't know if there's any other therapy in medicine, particularly in cardiology. I don't think there's any therapy that has been studied so extensively with sham-controlled trials. And the next step, which is a trial that is ongoing at the moment, which we are currently recruiting for in Perth here, is the Unmet Trial, which is a spiral large Unmet trial, similar to the pivotal off-med trial, where they're recruiting between 300 to 400 patients. And I think depending on the results of that trial, if the trial is positive, then RDN is likely to be accepted in mainstay as an adjuvant to treatment of hypertension. So this is the design of the Spiral Htn Unmet pivotal study, which we are currently recruiting for, and it's similar to the other trials. The patients are screened, and they actually undergo very strict screening criteria where they have to fulfill ambulatory blood pressure and office systolic blood pressure criteria, and ensure that they still remain within the blood pressure range, and then they are offered either renal innovation or the sham procedure, and the primary endpoint is looked at the 6-month mark. So renal innovation has not only been shown to be effective using radiofrequency energy, which is what the Medtronic device uses. Now, there has been another device which uses high-intensity ultrasound, which is the Radiance Solo randomized trial. So the device is different. The principle is the same, except it uses instead of radiofrequency, it uses ultrasound energy. And this is the Paradise catheter made by Recor Medical, and it has a balloon that is inflated, a very low pressure balloon, a soft balloon that does not cause any significant pressure effects on the lumen on the vessel wall, and has an ultrasound transducer within the center of the balloon. The point of the balloon is to ensure that there is cooling, and there's a coolant that is constantly circulated through the balloon that allows the luminal area or the endothelial area to be cooled down by the coolant, whereas the maximal effect is then in the periadventitial area, which is where the renal nerves run. This trial also had this device also had a sham control trial and showed that there was efficacious reduction in blood pressure in a sham controlled trial. So this is quite encouraging overall for the therapy itself to show that two different modalities have demonstrated this in randomized sham controlled trials. So there have been a number of published consensus statements over the last few years because of the number of positive trials that have been coming out in the last 2 or 3 years, and a number of hypertension societies have actually now include renal innovation as an adjuvant to therapy, adjuvant to hypertension therapy. One thing I wanted to briefly touch on was the other effects of renal innovation that could possibly happen. And this was a patient that we had a number of years ago, and this was actually quite incidental. This patient had polycystic kidney disease and had significant renal pain from the expanding cysts, especially when she had, there were some weeks when she had to be on opioids a few days a week. She was referred for renal innovation for hypertension. And then at that point, I was looking at it and we realized that the renal pain fibers actually travel along with the renal afferent nerves. And there was a likelihood that ablation could ablate the pain fibers as well. I did speak to her. I said, we don't really know what's going to happen. So about a week later, I rang her after the procedure and asked her how her pain was going. And she said, it's nearly gone. She had almost complete relief of her renal pain. So this is quite an interesting, finding, and it has led to subsequent other procedures being performed and other referrals for renal pain. Going back again, surgical denervation had been performed for resistant renal pain. Obviously, there's a very small number of patients, but in this group of patients, it can be life-changing. And just to finish up, I'll just show a real-world case. This was a 62-year-old male who had hypertension for about 7 to 8 years. And in the past 2 or 3 years, the blood pressure was proving difficult to control. I was on 3 antihypertensive medications and was intolerant to beta blockers, and did not tolerate spironolactone as well, and blood pressure was quite high, and secondary causes were ruled out. So this patient was referred for renal innovation. One thing to remember is that in a significant number of patients, I think about 20 to 30%, there can be accessory renal arteries, and sometimes there can be multiple renal arteries. So when you do the renal angiogram, it is always important to look at the renal parenchymal opacification. If the whole kidney, the whole shape of the kidney is not outlined on injection into a renal artery, if there's a lower pole or something missing, that indicates that there might be another renal artery. Because it's often easy to just do a selective renal angiogram and assume you've got all the renal arteries. But it's important to pay attention to the renal parenchyma filling up. So this patient had renal innovation with the spiral catheter. This was delivered quite distally into the branches, both the upper branch and the lower branch, quite successfully. And also on the right side actually had a larger main, and you can see that there's a small accessory going to the lower pole. You can see from the image on the left that the shadow of the kidney seems to have the lower pole missing, and that gives you a clue that there is an accessory artery. Any artery that's more than 3 millimeters or between 3 and 8 millimeters is suitable for renal innovation with the spiral catheter, and hence we performed denervation in both the branches of the, in the upper main branch. This catheter is delivered over a wire, and then the wire is withdrawn, and the catheter has the inbuilt ability to form a spiral shape when you withdraw the wire, and the spiral shape of the catheter essentially means that the 4 electrodes are now in a spiral pattern, and that allows 4-quadrant ablation. And then you pull it back and perform this at multiple locations. And this was a lower pore ablation, the lower accessory artery ablation. You can see the 4 dots, those are the 4 electrodes. This is different to the original device with which the initial procedures were performed. That was used performing a single electrode catheter. These catheters are passed over a wire, a somewhat supportive 014 wire, 6 French compatible through a 6 French renal guide. And then the wire, once you are in a good position, the wire is withdrawn and the catheter forms a spiral shape once the wire is withdrawn. And if you are happy with the position, which is determined by a few factors, but essentially the ablation device itself is quite, it tells you whether the characteristics are optimal for ablation. So you really don't have to do too much in terms of adjusting voltage or anything. It is all within the algorithm. Essentially, you place it there and you deliver the energy. And once if there's any movement or if there's inadequate temperature rise, then the device automatically stops delivering energy. This was the 3-month blood pressure post-RDN recording. There was a significant drop in office as well as ambulatory blood pressure drop. And we've had numerous such patients. Obviously, the patients within the trial remain blinded to the operator. So what happens is I don't see the patients before the procedure and after the procedure, whereas a group of patients, the team that is following the patients up after don't come to the procedure. I don't know what kind of procedure they've had. Thank you very much for your attention.
Shetty. It was a wonderful talk and a lot of new information regarding the RDL is you could able to convince us. I just have a small question. Before I go to the question, Dr. Padmanabh Kamath, who is a co-chairperson, I'd like to hear from his view about RDN and he has anything to ask Dr. Shetty. Dr. Padmanabh Kamath.
Thank you, Dr. Sharat Shetty, for that very lucid and excellent presentation on RDN. I think resistant hypertension has always remained as an enigma, especially people who are taking 2-3 drugs, and we always up-titrate the dosage and yet fail to achieve optimal blood pressure control. Simplicity trial failed to explain or allude to the complexity of resistant hypertension. I think it had a lot of caveats, mainly the 3 I's, that is the incomplete denervation, inexperience of the operator, and improper case selection. And after that, the spiral hypertension trial, which was beautifully illustrated by Dr. Sharat Shetty, has shown a lot of promise, especially in the real world scenario of resistant hypertension. I want to ask Dr. Sharat Shetty, in a situation like ours where we don't have the RDN readily available, how aggressive you are with the control of hypertension, especially the medical therapy, because we get patients with resistant hypertension, blood pressure in the range of 200 by 110, 120 like that, with not so bad renal parenchymal changes. And yet patient's BP doesn't get controlled with 3 drugs and with the addition of a spironolactone. What do you do in such situations? We cannot advise RDN for all our patients because of the lack of availability of the procedure. So could you just enlighten us on how aggressive your medical therapy is in treating such patients?
Thank you. Thank you, and namaskara. So I think we do try to treat them quite aggressively. People do tend to go on to 5-6 drugs at times. obviously, as you're aware, the compliance starts going down when you add these medications. And you're right, obviously, spironolactone is one of the things we would try early. Assuming one is obviously ruled out secondary causes and made sure there's no hyperaldosteronism and so on. We do tend to also go on to a central central alpha stimulants as well. Oxonidine, we try that. Sometimes that helps. So often people do end up on 5 or 6 drugs, and as you state, despite that, sometimes blood pressure is fairly high, and then we do make a compassionate case for renal innovation. What happened here is that even with us, once Htn3 results came out, the government actually withdrew funding for renal innovation as a procedure. So it had to be performed only within the realms of a clinical trial. So for patients like this, we do get compassionate grounds approval and then try to offer the procedure, particularly if they're on 5 drugs and so on, and on suitably maximally tolerated doses.
Dr. Shetty, I have a question. In your clinical practice, in our clinical practice, we find difficulty in treating the CKD patients, and they've done multiple drugs, and some of them, despite 5 to 6 antihypertensives, they keep their pressures could not be controlled at all. So, in your clinical practice, what percentage of CKD patients you treat with RDN?
So, initially, we kind of excluded anybody whose eGFR was more than 45. This was in line with the original studies. But I think there is good reason to suspect that renal innovation would actually work well in these patients. In fact, we're actually doing trial with the Paradise, with the ultrasound-based catheter that I touched upon earlier, particularly in CKD patients, to see if it helps in that group. So there has been some small studies that have shown some efficacy, but this is going to be specifically looking at CKD patients. One of the issues with the CKD patients is that their renal arteries tend to be smaller, and especially the kidneys have become, with advanced CKD, the kidneys become smaller and the renal arteries become smaller. And with the original catheter, they had problems with a lot of overheating as a result of it, because the RF catheters depend on renal blood flow for cooling. And if there's not enough blood flow, if there's small caliber vessels, then it gets a bit harder. But with the current generation catheters, it's certainly possible.
Thank you, Dr. Shetty. Wonderful explanation. Dr. Padmanabh Kamath, do you have anything to ask or anything to add to the present scenario? Do you have anything to add?
No. Thank you very much. Thank you.
And thank you very much, Dr. Shetty. We had a wonderful insight into the RDA. And thank you all the way you have spoken from Australia. We are very happy to receive you. Thank you very much. Thank you so much.
Thank you so much. Thanks for having me.
Thank you, Dr. Sharat Shetty. Thank you, chairpersons. Moving on to our next talk by Dr. C. Raghu on the topic of GDMT in de novo HFrEF patients, case-based discussions. To chair this session, we have Dr. T. R. Raghu from Bangalore and Dr. M. Bhatt from Bangalore. Dr. Yusuf Kumble from Bangalore. Over to you, chairpersons.
Yeah. Good morning, delegates, and thank you for the organizers for giving me this opportunity to speak on guideline-directed medical therapy in a de novo heart failure patient. I have my good friend Dr. Yusuf Kumble as the chairperson for this session, and I think and Dr. T. R. Raghu is also a good friend. Yeah, hello sir, how are you? Raghu meets Raghu again, sir. Yes, sir. So with your introduction, I will start, sir, after this. Suddenly they spotlighted me, so I had to start.
Yeah, Dr. Raghu, long time no see.
Yes, sir.
Last
Yes,
time we
yes.
have been to Mangalore, I think a few years back.
I always cherish it.
Nice to see you again. Yeah, you can go ahead with the talk.
Yeah, good morning, sir. Good morning, sir. So with my senior colleagues and friends, let me start sharing the screen. So this morning,
you can remove your mask, I think. You can remove your mask.
Yeah, but I'm in a little. I will come back to that.
Now we are addicted to that. We cannot work without that.
Okay.
It's a fashion also. Okay, sir. Let's come back, sir. So what we have this morning is a presentation on the guideline-directed medical management for a de novo heart failure patient. So I would try to present this session under two groups. One is the role of what is the latest European Society guidelines of the 2021 and how they are going to impact, and what is the phenotypic determination of a heart failure, how you treat these heart failures. So it is becoming more and more personalized heart failure management. That's what we are seeing nowadays. That's number one. And that's what the guidelines are asking us to do, more a personalized treatment for heart failure. And the other side is we have got the revolutionary molecules like the Arni sacubitril valsartan combination. How to use them? Can we use them in a de novo heart failure? Is another drug, because these are molecules which this is a molecule which I thought I should focus based upon our personal experience, and a lot of attendees will get benefited on the tips and tricks to use this molecule in their day-to-day practice. So with this, I would request the chairpersons to allow me to share the screen. Give me a moment. And wait a moment. Yes, okay. Sorry. Wait. One moment, sir. I have it here, but let me. Just a moment. Are you the dear organizers? Can you see my screen or no? Yeah, it's seen now. I think I can see here.
Yes, we can see.
Yeah, okay. Thank you, sir. Thank you very much. So this morning, I start with a case-based discussion. That is the topic of the day. So we will go with the case discussion about a patient whom we can see in our day-to-day practice. What's happening now? One moment, sir. Yeah, okay. Thank you. So this is a 45-year-old male who presented with a history of myocardial infarction about 7 years before, and he had a thrombolysis and he underwent angioplasty, and he had a severe left ventricular dysfunction. So these are the type of patients what we see in our day-to-day practice, old myocardial infarction coming to us with heart failure, and who has been all the while on the treatment for the routine management of its associated diabetes, hypertension, and so on and so forth. So such type of a patient, when they come into the hospital, we usually in the at a lot of people level, we try to manage them with a diuretic, we manage them with the ACE inhibitor, beta blocker, and anti-diabetic medication. But these are the group of patients we do see that these patients get re-hospitalized and then they have a lot of systemic congestion. So now, right now, the latest 2021 guidelines of the European Society of Cardiology, because this is a GDMT-based treatment, that's the topic today, so guideline-directed medical therapy. So what we have to differentiate is, as per the guidelines, whether this is a patient who we start these patients on the 4 pillars of the anti-heart failure therapy. The 4 pillars being ACE or ARNI, beta blocker, mineralocorticoid receptor antagonist, dapagliflozin, and empagliflozin, and loop diuretic only for a symptom relief benefit. So with this fundamental treatment, how we need to initiate the treatment is something which we can discuss during our group discussion, but these are the 4 pillars of heart failure, what we need to do. So if you look at the primary slides of the European guidelines, so this is what they expect us to do all our patients on the 4 pillars. So once you put this on 4 pillars, then beyond the pharmacological therapy, we need to move on to the device-based therapy. So the device-based therapy, as we know, whom like practicing interventional cardiologists, we look at the QRS duration, we look at the left ventricular ejection fraction. If the ejection fraction is less than 35, QRS duration less than 130, we have a strong indication for an ICD for a ischemic type of a heart failure. So which becomes a class 1 indication for a ischemic LV dysfunction with a QRS duration less than 130. The evidence for a non-ischemic LV dysfunction is there, but not as strong as that for a ischemic LV dysfunction. Now, let's say if the patient has got symptoms of heart failure with reduced ejection fraction and left ventricular ejection fraction is more than 35%, then usually we can consider the treatments and look at the other whether the patient is doing good or not, and based on that you can decide what to do. But if the patient has got a QRS duration of more than 130 milliseconds and ejection fraction less than 35%, and look at this one, the patient is in sinus rhythm with an ejection fraction less than 35% and a QRS more than 130 milliseconds, we look for a option of a CRT-D or a CRT-P. If it is more than 150, we need to go for a CRT-D. And if it is between 130 to 149, then there is a possibility that remains a class 2A indication. So it's a must here, and this is definitely to be considered. So what the change in the way how we look at heart failure management in 2022 would be a combination of medication plus a device. That is the way to go forward in the management of a heart failure with reduced ejection fraction. Any patient coming to us for the first time with a congested symptoms, diuretics are for symptom relief. So we have now, if you look at now the 4 groups of drugs, these are the drugs what we call now as a disease modifying agents, like what we use for the autoimmune disease or rheumatological problem. So there are drugs which are giving symptom relief. There are drugs which can give you a disease modifying agent. The 4 pillars being the disease modifying groups of the drugs. Now, you got, as you have seen in the first group of the previous slide, we have established that these are the 4 pillars of heart failure as per the latest guidelines. And if you can see in these guidelines, the major thing is the addition of the sacubitril valsartan as a replacement for ACE inhibitor to reduce risk of hospitalization, heart failure, hospitalization, and death. So any patient who is unstable on ACE inhibitor also, it is preferred, it's a class 1 with a level of evidence B that we need to start these patients on. We need to replace an existing ACE with a sacubitril valsartan. But if you can see here, all these 4 drugs have to be started. There was some sort of discussion in between by certain authorities that one group to be started first, one group to be next. But in my practice, I do not usually do that. I think we need to start all the drugs as early as possible and escalate them as faster as we can. That is what is the fundamental thing. So the important new guideline is the indication of sacubitril valsartan as a replacement for ACE, even though the patient is stable. So that is what I wanted to make. Then coming to the drug dosage. So they have given a drug dosage, you start slow, but you escalate to the highest dose. For example, very commonly, people tend to use Ramipril 2.5 and go up to 5 milligram BID. But at the same time, if we are giving a sacubitril plus valsartan, you start at 100 milligrams twice daily and go up to 200 milligrams twice daily. In the past, we used to start with 50 milligrams twice daily. Now, what they recommend is the starting dose has to be 100 milligrams twice daily and go up to 200 milligrams twice daily. That is the guideline directions in the 2021 guidelines. So this is also another important modification compared to the past. Now coming to the second group of drugs, what we use commonly would be the beta blockers. Now coming to the beta blocker, let's say commonly what we use is carvedilol. Let's say that's what I use. All groups of drugs, all of us use. But if you say carvedilol, you start with 3.125 and you can see the maximum target dose. It's not the maximum permitted dose. If you look at this table, you need to target a dose of 25 milligrams twice a day. So there is a significant change in the nomenclature compared to the past, where they say that you start, but you need to achieve the target dose of 25 milligrams twice daily. Now coming to bisapralov, you start at 1.25 and go up to 10 milligrams once a day. Nebivolol also similarly. So what I wanted to tell you is there is a change. For example, metoprolol extended release, we go up to 200 milligrams once a day. So that is the target what we need to achieve. So we can discuss among our panel discussion whether we are able to achieve these target doses or not. Now coming to the third group of drugs, that is the mineralocorticoid receptor antagonist. So these MRAs also, you start little low, but your target for both the molecules is around 50 milligrams once a day. So this is how we need to use a ACE/ARB, and the new kid or reasonably new kid on the block would be the SGLT2 inhibitor, where you start at the same dose and there is no further escalation of the dose. The target dose remains the same. So with this, what I would like to conclude is these four groups of drugs, starting doses, target doses, are the things which we can immediately replicate into our clinical practice and make it better, how to manage these patients. Now, there are certain new groups of drugs, like, for example, ivabradine and vericiguat. So if you look at this ivabradine, we start at a dose of 5 milligrams and then go up to a dose of 7.5 milligrams twice daily. Vericiguat also, as we discussed further, we start at 2.5 and go up to 10 milligrams once a day. These drugs, ivabradine is available, all is long available, and vericiguat is soon to be available. Now, there is a role, if you can see once again, digoxin is about 62.5 micrograms and then go up to 250 micrograms OD, and for hydralazine and isosorbide dinitrate combination also, they are given the target dose and the starting dose. Now with this, we have completed the disease modifying agents in the treatment of heart failure. Now let's go on to the management with the symptom relief drugs, like a patient who received the diuretics for symptom relief. That's also class 1 indication, level of evidence C. It is for symptom relief, improvement of exercise capacity, and reduce hospitalization. But as we all know, it has the diuretics, loop diuretics do not have a role in the management of a mortality, or do not have any relief on the mortality or impact on the mortality. So the diuretic, what we need to choose is not a thiazide or a thiazide-like diuretic, but the diuretic what we need to choose for symptom relief is a loop diuretic. Okay, now there are there are the group of the angiotensin receptor blockers, that is as an alternative to ACE or ARNI. So all patients at the moment receive an ARNI as the first line of drug, as you can see in the second part of the presentation. But we use these drugs to, and we use these drugs if the patient, in rarely nowadays we really use a ARB alone. Either we use a, most of the patients tolerate an ARNI in my day-to-day practice. Now coming to, because this is a session which is guided, which is focused on the physicians and cardiologists. So I thought that let me discuss with a couple of more molecules which are already in practice and how to use them. Ivabradine. Ivabradine is a IF, what we call as the fast channel inhibitor. So what we need to do is this group of this molecule like Ivabradine, we should use when the asymptomatic patient, ejection fraction less than 35%, patient should be in sinus rhythm and heart rate should be more than 70 beats per minute. And despite giving a beta blockade or up to maximum tolerated dose ACE, MRA, and beyond that. So we are giving the entire 4 pillars of heart failure, including a beta blockade. After that also, if the heart rate is more than 70 beats per minute or ejection fraction less than 35%, patient is in sinus rhythm, very important, then we should give Ivabradine. Even for that also, the level of their class of recommendation is 2A with a level of evidence only B. For example, sometimes we are forced to use this Ivabradine because the patient is unable to tolerate a beta blockade. So this is a new addition where if the patient is unable to tolerate or have contraindication, that also has become a class 2A. But we should not give Ivabradine alone, but it has always to be given with a other disease modifying agents like ACE, MRA. So my dear friends, so the major difference is now the guidelines recommend that if the patient is not able to tolerate a beta blockade, you can start Ivabradine early rather than not starting it. So that is an important modification in the latest guidelines. Now coming to a new drug, that is the Versuguat, which will soon be launched in 2022, or it has been launched. So for those patients who have already received ACE or ARNI, beta blockade and MRA, and who have a worsening of heart failure, we can consider Versuguat, which is a class 2B indication. So this is another group of drug what we need to use in our day-to-day practice, especially for those who are refractory on the all 4 pillars of heart failure. Now coming to the other group of drugs which is routinely used by certain practitioners and in certain subsets of patients, the combination of isosorbide dinitrate plus hydralazine. So what happens is, this is also a very new new thing. One group is we all do that in the patient is unable to tolerate or has got contraindication to ACE ARB, like patient has got renal dysfunction. We always start these patients on a hydralazine isosorbide dinitrate. That's a class 2B. But what you can see is a very important thing is in certain subsets of patients, obviously we do not have the Indian data, but in those patients with self-identified black patients and who have a dilated ventricle, and despite treatment with ACE, ARB and beta blocker and MRA, that means you're already on all the therapies. So the isosorbide dinitrate plus hydralazine has emerged as a class 2A for those patients who are already on good treatment but not responding well. So that is another new addition in the 2021 guidelines, where you have got one more reserve drug, Versuguat, dinitrate, hydralazine, are a group of the reserve drugs in heart failure which are available. Now coming to our old friend Digoxin, it remains a class 2B who have in sinus rhythm and symptomatic heart failure, who have got beta blockade and ACE and still as a reserve drug after giving all these drugs. If the patient is in sinus rhythm, you can see here, reduced ejection fraction with sinus rhythm with all the drugs, still it is there, then possibly you can consider the use of a digoxin. So with this, I think once again, we come back to the phenotypic view before we conclude the first part of my presentation, that is on the reduced ejection fraction. What is the guideline directed management? To reduce mortality in all patients, we have to give ACE, ARNI, beta blockade, MRA, SGLT2 inhibitor. That is for sure. To reduce hospitalization or mortality, hospitalization, heart failure hospitalization for selected patients, we have to give diuretics. If the QRS duration is more than 150 milliseconds, then you can do a CRTD or CRTP. If the patient has got a QRSD less than 150, and if it is an ischemic etiology, ICD is best. Then so this is up to this what we have discussed. Now you have to look at what are the groups of drugs where you should give. For all patients with atrial fibrillation, as we do now, we give anticoagulation. For patients who got a aortic stenosis, we always do a mechanical therapy of a surgical or a transcatheter aortic wall replacement. And if the patient has got the other things which are all in yellow, like certain other associated comorbidities, we need to treat them, like iron deficiency with ferric carboxymaltose. Patient has got CAD, treat with bypass. Atrial fibrillation, you can do for a pulmonary vein isolation or digoxin. Mitral regurgitation, you do a TEER. Heart rate more than 70, you use an ivabradine. If the patient is a black patient, then you can consider isosorbate dinitrate plus hydrolysine. And for selected high-risk patients and advanced heart failure, like quite a few centers in our country, like looking at heart transplant, mechanical circulatory support, and long-term mechanical circulatory support, even though they are very expensive, can be reserved for certain subsets of patients. But most importantly, if you want to reduce the hospitalization, my dear friends, the physicians who are attending, the importance of exercise rehabilitation and a multi-professional disease management to reduce the hospitalization and improve the quality of life. That is what we all strive towards. So this is what we need to do for our patients. So now with this, I think I will not go too much into the others, like one more final point, because a lot of my interventional cardiology friends are there. Whenever a patient is there with heart failure and where you think that it is a restrictive entity, we should have a little lower threshold to do a right heart catheterization. That is one in the latest guidelines. And very importantly, in HFpEF patients, we need to do a right heart catheterization. That means we need to consider or possibly consider the importance of right heart catheterization, which in my practice, I try to do it in a much more liberal way for our HFpEF, because it helps us to guide the therapy in a better way. So with this, let me go on to, I will just stop sharing the screen, or no, I can continue to do this, I think. No, 1 minute. Now we go on to the second part of the presentation, how we use this new group of drugs, that is the ARNI, in our day-to-day practice. We all know that in our day-to-day practice, how many of them are de novo hospitalized. So in my practice, I would say that every out of 10 heart failure, right now, about 5 out of 10, or even little more also, 6 to 7 out of 10 heart failure patients who are getting hospitalized are de novo heart failure patients. Because in the past, we never had these 4 pillars of heart failure therapy. Once we put our patients on the 4 pillars of heart failure therapy, I do see that there is a significant reduction in the need for rehospitalization. So that is what we are doing. So now let's say, take this lady as an example, who has an ejection fraction of 32%, creatinine of 0.5, GFR is reasonably okay, potassium is 4.2. So a lady who had a recent myocardial infarction or who had with a de novo heart failure, now what is the management of these patients? In the past, what we need to do is, how does a de novo heart failure worsen from a chronic worsening heart failure? So de novo heart failure is more common in women. These people tend to be much more younger.
Excuse me, sir, we are not able to see your screen. Can you please share it?
Oh, sorry, sir. Sorry. Okay. Sorry. I'm sorry. I will close this and bring it back again. Okay, one more time. So let me share the screen again, sir. Sorry. One moment. Sorry about it. Can we see it, sir, now? I think we can see now.
Yes, we can.
Yes,
I'm sorry about it. I'm sorry. I did not recognize it. So now let's come to the, thank you very much for, so we have, whenever we see these heart failure patients, we have got two groups of heart failure patients. One is those patients who have already been hospitalized in the past and coming for rehospitalization, and those patients who have been admitted anew for heart failure. So we are concerned with that group of new heart failure patients, which have become more common compared to the past, because right now we are able to manage our heart failure patients better and prevent rehospitalization. That's what our new drugs, the disease modifying agents, have allowed us to do. So when we have a de novo heart failure, how does a de novo heart failure differ from a patient who had a previous heart failure? So most of these de novo heart failure, as I can see in my practice also, are mostly women. They have got, when we do their angiograms, they are normal. They are much more younger. And most importantly is, these are the patients who have got lower rates of mortality. And these patients are not the run-of-the-mill patients who have been included in large clinical trials. So we do not have a clear data. I hope the screen is seen, no?
Yes.
Yeah,
Very well seen.
Very well seen. Thank you, sir. So now, whereas on the other hand, when you see a recurrent hospitalization patient, these are mostly ischemic, men, elderly, high rates of mortality and readmission. Because nowadays we are doing angioplasties and pharmacological revascularization much early, this group of patients, we made a significant progress in their management. Whereas in the first group, we still are having a lot of challenges. So now in this de novo heart failure, the mortality rate compared to that with the previous, or this is what we call in certain diagnostic, certain studies as acute heart failure. The de novo heart failure is called acute heart failure, and the patient who has got a previous heart failure and worsened is called as acute decompensated heart failure. So this acute AHF versus ADHF. So the mortality remains the same, and mortality continues to remain. So how can we make a difference for these patients is the second part of our talk. The in-hospital mortality of about 5%, 6-month mortality of about 15%, ICU readmission rate of 55%. And most importantly, when we manage these elderly women who have a non-ischemic etiology with atrial fibrillation, they tend to stay long for the management of heart failure compared to that of a reduced with a different type of a previous ischemic etiology and a reduced ejection fraction. And what happens is, most of these patients, if they do not get a guideline-directed medical therapy, if you see, their chances of rehospitalization is much higher if they do not get all the 4 pillars. So if they receive all the 4 pillars at discharge, their rehospitalizations are less. If they do not get, then their rehospitalizations are much more. Now coming to the preferred treatment choice for these patients with de novo with reduced ejection fraction. When the initial trials of ARNI came in, it was to replace the existing ACE inhibitor. That was about 5 years ago. Later on, we started initiating ARNI for new heart failure patients also. Now, for a patient who is in the acute care also, we are using ARNI as the first line of drug. That is what is in my practice. Now, when you use a beta blocker, when you use a mRNA, we believe that these drugs have been established by the guidelines. So there is a lot of data, but that is not the true case. The data is not very strong for initiation of MRA or beta blockade in the intensive care unit for the control of heart failure. So sacubitril valsartan is the therapy, is the only therapy having an evidence for in-hospital initiation of heart failure therapies supported by the guidelines. And the 2000, as I showed you in the 2019 guidelines of acute decompensated heart failure, initiation of sacubitril valsartan rather than ACE or RB should be considered with a new onset heart failure or those with a acute decompensated heart failure to reduce the short-term events and all that. So there is no need. For example, many times we think that let us use the ACE inhibitor to reach the maximum dose. If the patient doesn't get better, shift on to ARNI. That's not the need. You can straight away shift from the existing dose of ACE to the ARNI. And as I told you, the dose needs to be much more significant unless the patient isn't having hypotension and all that. So now the 2021 ACC guidelines also recommend direct ARNI rather than a pre-treatment with ACE ARNI. And ACE, ACC guidelines say that the best time to consider ARNI optimization is during the hospitalization time, and ongoing up titration of guideline directed medical therapy, including sacubitril valsartan, should be given for the treatment of these heart failure patients. Now, what happens with the impact when you treat these patients like that? Obviously, they have a lower CV death, rehospitalization. That's all we know. Compared to ACE with Vimeda, you have a significant improvement, and the chance for repeat rehospitalization is also reduced by 11%. So I'm sure most of us do agree with these numbers. With the availability of ARNI, our ability to treat acute heart failure has improved a lot with much less repeat hospitalizations, and also repeat mortality also is much less, and the patient remain asymptomatic, and similarly cardiac biomarkers are also less. With this, what I would like to do is we will stop this discussion here and then take some questions, and then I think that we can have about 5-minute discussion on the various points, because this is a practical point. We have two senior expert panelists, Dr. Yusuf and Dr. T.R. Raghu, and we can take this discussion forward. I don't want to repeat the same thing again and again, sir. Thank you very much, sir.
Thank you, Raghu, for excellent lucid talk. Actually, you have covered a lot of things. What has changed for the last 5 years, probably, we have got a better drugs. There are 4 drugs for heart failure. That's all we should remember. Probably they have changed how we are going to treat heart failure and how we are going to prolong the life of the patient with heart failure, probably. We are reducing the symptoms. Probably we have to gain 2 to 3 years for a period of time if you treat them with guideline-directed therapy. I think what is important probably now, nowhere maximum benefit.
Yeah, Dr. Raghu, fantastic presentation. And as you rightly said, the approved heart failure therapy trial as well as evaluate heart failure trial both showed the reversal of cardiac remodeling with ARNI. It's a fantastic drug, no doubt. It reduces the readmission, it reduces the symptoms and rehospitalization. But there are some worries about these ARNI also. Many of them are not tolerated well, especially the dose they are mentioning, 200 milligram and all, not tolerating well. Especially hypotension is a very much a worry. And then, of course, those who are marginally, most of our heart failure patients will be having kidney failure along with heart failure. So the borderline creatinine can jump and hyperkalemia can be a problem. I don't know, how do you manage? What is your cutoff blood pressure when you are put on ARNI? Most of my patients have seen that 90, 100 is the standard blood pressure for most of the patients.
Thank you, sir. Thank you. Am I audible?
Yes, very well.
Very much audible.
Yeah. Thank you. Thank you, Dr. Yusuf, for a very important practical. There are three issues which Dr. Yusuf brought. One is the problem of hypotension. The second is the problem of hyperkalemia. The third is the problem of the worsening of the renal function. So the first thing is hypotension in heart failure is mostly due to hypovolemia. So whenever we uptitrate our ARNI, we should always look at the opportunity. Once you stabilize your acute heart failure patient, you down titrate your diuretic. That is the time when you have to uptitrate your ARNI. That's what I do in my practice. Then, if you give a high diuretic and a high ARNI, obviously hypotension is the problem. So that is what, and then sometimes when we give this ARNI, if they are fluid depleted, that is when a renal function worsening also happens. So you have to look at, especially when we are giving dapagliflozin, when we are giving a torsemide or a Lasix, you need to be sure that what is the input-output charting, daily weight monitoring, and then gradually down titrating the loop diuretic and up titrating the ARNI is the key to reduce the impact on hypotension. The second is the problem of hyperkalemia. There are data to compare the hyperkalemia of ARNI vis-a-vis ISCA, which says that ARNI has got a lesser potential for hyperkalemia, and this has been my experience also. ARNI hyperkalemia is a problem, especially we have got the renal dysfunction. So the renal dysfunction I will discuss in the next question. So the ARNI, we obviously monitor the renal function, and we keep a track for the first, let's say 3 to 6 weeks, and then if it is normal, usually they do not develop hyperkalemia over the long run. Now coming to the third point is the worsening of the renal function. When we are looking at the worsening of the renal function, we have to look at the eGFR before we start the ARNI therapy. If it is less than 30, then we do not uptitrate the dose. We give it 50 milligram twice daily. If it is less than 15 eGFR, do not start ARNI. If it is more than 30 eGFR, then you can uptitrate your ARNI. But whenever, as I told you previously, there will be a certain worsening of the renal function of about 25 to 30%. As we have learned, Dr. Yusuf, from our previous experience with ACE, those patients who have got a 25 to 30% worsening of the renal parameters after starting ACE ARNI, those are the people who are going to respond better to the treatment. So initial worsening of up to 25% is acceptable, and even if it is worsening, I would continue to use the medicine, because this is the group of patients. It's a marker for me to identify who is going to benefit, who is not. So that is how I track the problem of the renal dysfunction also.
Yeah, excellent discussion, Dr. Raghu. And Dr. Raghu, any other questions anybody is having?
Sir,
there was questions in the group.
Sir, with the interest of time, we have to move to the next session, sir, please.
Yeah, thank you.
Okay.
Thank you very much.
Thank you
very much,
Excellent.
Dr. Raghu.
Yeah, thank you, Raghu sir, and Dr. Raghutia, as well as Dr. Yusuf sir. Thank you for being part of the session. Moving next.
Thank you.
Our next speaker is Dr. Selvamani from Madurai on the topic Devices Selection in Cardiogenic Shock. To chair this session, we have Dr. Tom Devasya from Manipal and Dr. Narasimha Pai from Mangalore. Over to chairpersons.
Morning, Dr. Selvamani. So we meet again.
Good morning. Good morning.
We are looking forward to your talk. And Dr. Selvamani is a very popular figure, both in South India and all over the country. He is working in Meenakshi Mission Hospital, Madurai, and I loved his bubbly talks and the wonderful live cases he do, and especially his special interest in OCT and complex coronary diseases. Lots of awards, lots of research and articles, and a lot of paper presentations, both nationally and internationally. I welcome Dr. Selvamani to proceed with your talk. Thank you.
Thank you very much for the opportunities, Dr. Manjunath and other organizers there. And but today, I'll be talking predominantly on the type of devices that we use in cardiogenic shock. So as we all know that cardiogenic shock is a very important aspect. And it's a new field like where we have a lot of new things to learn. And practical usage of this is also very, very important. So after saying this, am I clear? Can you hear me?
Yes, yes, very clear. Please proceed.
So we have different types of classifications for cardiogenic shock. The very important thing is the SKY expert consensus. And I think most of you are very familiar with this. This is A, B, C, D, E. It all depends on the presentation and the risk of death in that patient. And then we have certain criteria which are very, very important in a patient with cardiogenic shock, especially cardiac index and pulmonary wedge pressures and cardiac power output. These three things are very important, which decides the patient's mortality as well as the type of device that we are going to use there. And very simple way of classification, instead of confusing all those things, what we can do is we can have a very simple classification like pre or early shock, shock and severe shock. So blood pressure is one important thing, and lactate levels, and of course cardiac index, as I already told you, cardiac power output, and then your pulmonary wedge pressures and LVEDP are very, very important. So when the cardiac power output is less than 0.6 and pulmonary wedge pressure is higher, cardiac index is lower, the patient is definitely sicker there. And probably these are the medicines which we generally use in patients with heart failure. Although there is no mortality benefit, definitely it gives confidence, increases blood pressure, and probably a mild increase in cardiac output. Now coming to the per se, the very important the topic for today, that is what all devices we have for cardiogenic shock. So we are all very familiar with IABP. Next comes ECMO, and then we have Impella, and of course tandem heart. This is not very common here in India. These three devices are quite popular, or probably becoming popular. We will just go through how it works. So what happens is each device has its own limitation, and it produces an increase in cardiac output to some level. So for example, IABP is probably 0.5 to 1 liter increase in the cardiac output, Impella 2.5 and probably Impella 5, and ECMO, of course. These are very important devices where it increases the cardiac output very well. And when you compare the hemodynamic effects of this, see, when you look at the IABP, as I already told, cardiac flow is increased up to 0.5 to 1 liter. Impella, depending on the type, 2.5 to 5, we can increase it up to 5 liters from 1 to 5. And ECMO, we can run the speed to maintain a cardiac output between 3 or 2.5 to 7 liters, depending on the requirement. And you all know the mechanism. Only to highlight, this is only in the aorta. Impella is directly from the left ventricle to the aorta, it pumps out. And this VA ECMO, of course, we have different types, but one is you take out from the venous system and put it into the arterial system, and you maintain a peripheral circulation with a pump there. So that is what is the ECMO principle. And these are the sheets which we use for using it. Different size. IABP is the most simplest, probably 7 French sheet. And probably Impella, we need a bigger sheet, than ECMO also we need a bigger sheet here. And very important aspects is afterload is a very important factor in cardiac failure. So IABP and Impella both reduce the afterload, but this is a disadvantage of ECMO. It tends to increase the afterload because the blood is pumped into the aorta, so heart has to work a little bit more in ECMO, but although perfusion, BP, cardiac output is maintained with this, but at the risk of slight increase in afterload there. And mean arterial pressure is increased by all these devices. And LV-EDP, you see here, both IABP and impeller reduces the LV end diastolic pressure. Naturally, pulmonary capillary wedge pressure also comes down. But ECMO, as a neutral effect, or sometimes it can increase the LV-EDP. That is a problem. So these are the perfusion, and myocardial oxygen demand also is reduced by these two devices. And this, as the afterload is high, probably might increase the demand. Is neutral there. So this chart is very, very important when you decide how we are going to select the device. The very important thing is the normal pressure volume loop is bounded by end systolic pressure volume relationship and end diastolic pressure volume relationship. This is what is very, very important. That is why we should keep in mind which device increases the EDP and what is the solution if there is something like that going on there. So main important benefit of circulatory system, mechanical circulatory system, it maintains vital organ perfusion. That is why where it prevents the shock syndrome. When the BP comes down, cardiac output is low, generally it produces a systemic reaction. So it might go into shock syndrome. To prevent that, it's a very, very important device. It reduces intracardiac filling pressures, reduces congestion, reduces pulmonary edema, reduces left ventricular volume, stress, and myocardial oxygen demand. So this is the cycle that we should always be aware, and we should not allow the patient to go into that. So once the patient develops the systemic syndrome of shock, it's very difficult to reverse it back. Death is probably the very chance that when the shock is well advanced, going into systemic shock syndrome. So to prevent that, what all things we should do is very, very important. And but these are the important aspects of device, which is useful nowadays. When you initiate at the right time, it is going to prevent this shock syndrome. Probably we can help few patients there in recovering faster from this shock here. And very important, as I told you, is the time at which you start the device. And you should have a circulatory support system. You should maintain the arterial pressure, keep the lactates under control. And probably these are the very important aspects. Apart from the support, then you'll have to do an adequate perfusion if it is an acute coronary syndrome, and look into the renal and liver issues also to maintain the patient in a good condition. So we should remember one rule: to maintain an adequate saturation, an output of 70 ml per kg body weight is essential so that you avoid this shock syndrome. When you come to ECMO, as I already said, the blood is removed from the venous system, that RA, or you can remove it from the femoral vein or IVC, and then it goes to the oxygenator, to the pump, and then it is pumped into the aorta, and from the aorta again into the left system. So basically, this is the system which goes on in an ECMO issue. And as we already showed, it increases the LV preload as well as the afterload just because of the increased blood into the aorta. And this can produce pulmonary edema, or it can increase the LV-EDP. So to do that in ECMO, what we do nowadays is we can avoid this rise in EDP by doing an atrial septostomy, but that's not very common. Surgeons, if they are doing, they generally keep a left ventricular vent there. So the blood is vented from the left ventricle into the aorta. Or you can put an IABP, or you can use an impeller, that is LV to aorta ventricular assist device, something like an impeller. So a combination of IABP or an impeller with ECMO will be an excellent thing, where the only disadvantage of ECMO was the rise in EDP, which can be corrected with this. Coming to IABP, should the use of IABP be absolute now, or should we just still continue to use it? There are a lot of trials which have said that probably IABP may not be so useful, but in our real-time practice, with our extensive more than 20 years, 25 years of experience of IABP, definitely we know that in which condition IABP will be useful, especially after the shock-free trial. IABP has been outdated, especially for acute MI circumstances, but still you can use an IABP. The controversy being probably these trials were underpowered, and then it's very difficult to compare two devices in such a serious condition. So keeping all this in mind, still the use of IABP is more when you compare any other device in India or elsewhere. IABP is used in more numbers when you compare it with other assist devices here. And the advantage of this IABP is very economical. It's available in most of the places, ease of implantation, less vascular complication, and we have different ranges depending on the height of the patient, balloon sizes. So these are some of the advantages of IABP. See, now this IABP has been downgraded because of these few trials which have indicated. AHA has still given it a class 2A indication, but of course in European it has come to class 2B, and routine use of this IABP is termed as class 3 in an acute MI cardiogenic shock position. Coming to Impella device, as I already told, this is how the Impella looked. See, the blood is pumped out from the ventricle into the aorta, and that is how it's a very minute mini pump which helps to maintain this cardiac output. And this is how the blood is brought out into the Impella into the aorta. So thereby decongesting the left ventricle and increasing the cardiac output. When you look at the clinical outcomes, when they compared a patient who had Impella, who had IABP, and who did not have any IABP, or whether when it was put pre-procedure, Impella definitely is better in these trials. There are CVAD study and so many other studies also indicate that. And coming to the mechanism, which I already told you, Impella is basically unloading. It reduces LVEDP, reduces end-diastolic volume, reduces mechanical work, increases, it's a cardiac protective signals are all improved. Perfusion injury is reduced, oxygen demand is reduced, supply is better. Cardiac power output is increased with increased flow there. So this is the advantage, and then this spiral of shock can be prevented. In comparison, LV ECMO, VA ECMO, it is all in the red. Whatever comes down here, it actually generally increases in an ECMO system. So that is why today we have a lot of options where you can reduce this LVEDP in an ECMO system. And we have combination of therapy in most of the circumstances today. See, it's a combination of Impella and ECMO in cardiogenic shock, which is very, very useful, especially if a patient has had a cardiac arrest. So these are some of the flow charts. We will just see how it works. And when you compare IABP with other devices, many trials have not shown excellent benefit with other devices also. IABP also has some role even today. Coming to device selection, there is one type of scoring system. This may not be very useful, but it's just a guide where you can follow this. What you can do is you can predict the mortality of a patient and you select the MCS there. So generally, this scoring system says that if the age is more than 73, history of stroke and glucose levels, renal creatinine, serum lactate, and each thing is given a score. And if the scoring is low, intermediate, and high, depending on that, we go ahead, decide the mortality, and then decide the device. So for the score, which is 0 to 2, the mortality is less than 20%. For the score 5 to 9, it is 60% mortality. So probably when the score is higher, you'll have to go for a more stiffer device. For example, if somebody's mortality is less 20 to 30, probably you'll have to start early. Then you'll have to you'll have to think whether IABP is sufficient or no MCS, whether to go with Impella and ECMO. So with all this available idea and knowledge, and guidelines also are not very precise. And many people, we don't put them on device because of so many reasons: cost, availability, familiarity. Some people, we put them on devices, some recover, some do not recover. So how to go ahead with this? We will come to that part. Just I will show you a few cases which I have done in our center, and then probably we can go to that final decision making. So this is a quite old patient, probably around 2010 or sometime at that time I have done. A patient with an extensive anterior wall MI, QRBBB, cardiogenic shock, a low BP. He comes almost 24 hours after the MI. and his lactates are also getting rise here. So this is the angiogram here. You see here, the LAD is totally occluded at the spot here, a very common scenario in that condition. What I have done is, at that time, we had nothing much. We had to intubate the patient. I have put a IABP. You can see that IABP working there. And then I'm doing a thrombosection in that LAD. And then put a stent in the LAD with a good result, excellent T3 flow. At that time, we used to treat even non-culprit vessels in patients with cardiogenic shock. He had a critical CTO-like lesion in RCA, but anyhow, I have treated that also at that time with good results. And see, this I have done somewhere in 2014. This patient is still good. He's doing well. One advantage of cardiogenic shock, what you should remember is, if you recover from cardiogenic shock, the long-term prognosis is comparable with any other patient who did not have a shock. So the importance of shock is you should come out of it in the early initial stage. And probably if they recover from that, long-term results are really good. This is another example for an old patient around 7-8 years back. And again, a patient in cardiogenic shock with severe triple vessel disease, non-QMI-like presentation. And with an IABP support at that time, I have put all the 3 stents and then recovered very well and doing fine there. So with whatever support we had along with inotropes, only IABP was available at that time. So this is slightly a little bit later in 2019 also, not much of other devices were available. So I have done a with IABP support for primary PTC in that patient. But this is a more recent, probably 2020 patient now. So he is an elderly man who comes with repeated pulmonary edema. This time also he has come with pulmonary edema and cardiogenic shock, severe LV dysfunction. ECG looks like this, wide QRS LVBB pattern. And this is his echo, severe LV dysfunction, having an MR there. And look at this echo. We just did a CT which was showing pulmonary edema. And then we assessed the viability also. It's all viable, but patient is very sick with such a low EF. And this is the angiogram. So how to treat this patient now? Well, I could have just done it with an inotrope, IABP, and then try to finish it. But it's a real complex disease, not fit for surgery. And distal left main calcified lesion, LAD, severe LV. It's a real chip case here. So what I did is we decided that we cannot just do with this IABP. Probably the chances are less. So this is the arterial BP in that patient. So then I went on an ECMO there, ECMO system. And this is the ECMO being implanted. ECMO sheet implanted, and we try to produce a cardiac output around 3 liters per minute. And we maintained on this. Now once on ECMO, look at this, BP, mean arterial blood pressure is improved. At the same time, as I told you, the pulmonary wedge pressures also increases when you put them on an ECMO, probably because of increase in afterload, LVEDP can go up. So here, along with this, pulmonary artery pressures also increased. So what I have done, I will just show you there. So this is the angiogram. I have put a temporary pacemaker. I know that it's a significantly calcified lesion. Non-dominant right, dominant left system with a critical left main disease there and a severe LV dysfunction. So I tried to pass a microcatheter. Microcatheter is also not passing beyond this point. Trying to push it, it is not going, but changed over to a rota wire, and I have done a rotablation. And with after rotablation, reasonably good. Then I have done a left main bifurcation stenting. And after stenting, to bring down the EDP, the option what I had is I had an IABP. So it's a combination of ECMO and IABP. Patient made of LV EDP came down, and he recovered from that procedure. This is the post-procedure IVUS as well as OCT, which demonstrated excellent results with good position. And this is our team generally how we do. And this is another example of an impella. A patient had a severe calcified lesion where we had to do with the mechanical support. This patient could afford, so we went ahead with an impella. with impella support, done a complex left main bifurcation. So to summarize, these are some of the few case examples that we do that. IABP, when compared with other devices, did not show me great mortality benefit. And similarly, impella also has shown to improve immediate outcomes and BP, but mortality benefits still we are not sure, although we know that mechanical support system will help patients with cardiogenic shock, and it's very difficult to prove in trials that it produces excellent mortality benefit. So today's recommendation is in any patient, it is a class 2A indication. We don't have class 1 indication for any mechanical device. And probably depending on the refractoriness, affordability, we can decide on MCS. But today, guidelines and recommendation, no clear-cut ideas on specific devices. And as I already told, not real great benefit, but still we are using it. It is going to be helpful. To summarize, what I can do is say you is if somebody has a cardiac arrest, then ECMO is very, very helpful. And to overcome the problem of ECMO, probably you'll have to use an IABP or an impella. This is one. This will suit any patient with this combination. And in a patient who does not have a cardiac arrest, and just probably IABP and impella are very, very useful in this group of patients. But in any patient, this combination of ECMO, impella, or impella, ECMO with IABP will be useful. You can make use of it. And today, to conclude, a combination of ECMO and IABP or combination is very, very helpful. And many times, how with zeros down is availability of the device should be available, patient should be affordable, and familiarity of the device is very, very important, not only for the intervention cardiologist, for the entire team. We need a teamwork, anesthetist, cardiac anesthetist, cardiac nurse, a small perfusionist, your intervention team, cath lab team, everybody should be familiar. Only then you can just start using it regularly. And to conclude, appropriate device selection is still complex. And as I told you, availability and then probably cost and affordability are very important factors which decides the use of these devices today. We need a multidisciplinary collaborative approach, and it's an integrated therapy. And to maintain this, I think you should slowly put up a unit, a team, and then you can succeed, try to help a lot of patients. Thank you very much for the silent listening and for the opportunity.
Thank you, Dr. Salvamani, for the nice detailing on cardiogenic shock and the role of mechanical circulatory support system. Yeah, we agree with you that even though the SHOCK 2 trial took away the confidence of the operator in IABP, we still continue to put it because it is probably affordable and easily available throughout our country. And like you said, in complex cases, maybe a combination of ECMO plus IABP would be more affordable option than a combination of impella plus ECMO. So Dr. Pai, some comments from your side, please.
No, I think I fully agree. Sir has summarized the available devices and their scientific evidence beautifully. I think as you told, we would also go with an upfront IABP in a patient with cardiogenic shock, though the scientific evidence is not favoring the use. But I think the operator comfort overrules the scientific evidence in this point in time. So whenever there is an AMI with a cardiogenic shock and you plan to do a PCI, it's better to upfront put an IABP, stabilize the patient, and then go ahead with the intervention. As far as impella is concerned, I think cost is a limiting factor in our country, and readily availability as well as the comfort of the interventional team is still an issue with the impella. Otherwise, if there are any other questions, we take it, or otherwise we thank sir for his wonderful talk.
Any questions for the speaker, please?
Thank you, sir, for being part of this session. Meanwhile, we thank our chairpersons, Dr. Nasim Pai, as well as Dr. Prem Birose for being part of this session. Thank you, sir. Moving next, we have a panel discussion. And we have with us Dr. R. Purushottam as a panelist. I request Dr. R. Purushottam to kindly go to the stage. And we have Dr. Padma Kumar from Mangalore as a one more panelist. And finally, we have Dr. Rajesh Patyu from Mangalore again as a panelist. And to moderate this session, we have with us Dr. P.V. Manjunath, who will be moderating this session on lipid dialogues.
Good morning, friends. I thought that there are a lot of things to discuss about lipid management because there are misconceptions, myths about statin usage in our clinical practice. Especially, we find that the physicians level, it has not percolated into the physicians level, and still there are a lot of issues with the statins. So I thought that this is a best way to clarify clarify some of the doubts which normally the physicians or even the clinical cardiology people have about the statins. So we have a very eminent panelist with us. Dr. R. Purushottam is Associate Professor of Cardiology at AJ Institute, my colleague at AJ Institute of Medical College and AJ Hospital, Research, Mangalore. Dr. Padma Kumar is the head of the department, Professor and HOD of KMC Manipal, and Dr. Rajesh Yu. He is Associate Professor of Cardiology, KMC, Mangalore. So today I have framed some questions which are very useful, and these basic questions which are very useful. So before we go for the panel discussion, can I change the slides, please?
Yes.
Which one?
Yes, right. Yeah, that one.
Yes. So cardiovascular, there is a global mortality from cardiovascular disease, and it has occurred more than 50%. Well-known fact, and particularly coronary artery disease is rampant in India. And when compared to Japanese, it is 20 times. When compared to Americans, it is 5 times. So there is a definite role for statins in prevention of the coronary artery disease. Just these are the one slide because Dr. Padma Kumar is going to speak about the plaque regression later. And this one of the asteroid trial in 2006 has shown, you can see that the atheroma area after statin has significantly reduced. So there is no doubt that statin also causes plaque regression. So now we have, other than we have OCT, IVUS, and CT angio, so many modalities of plaque imaging, which also contribute to the proving that the statins are useful in clinical practice. Now the factors affecting the lipid measurements, these are all things. There are some questions are there, like whether we should do fasting or random is okay. And even the posture, the plasma serum difference, tonic application, and lab differences are common. So now, my first question is to Dr. R. Purushottam. So what do you feel in your clinical practice? Do you think that all the patients who go for lipid management, are they going for fasting, or you still believe that there is some group of patients who can be non-fasting lipid providers? What is your opinion?
Yes, as we all know, lipid estimation or the serum lipid profile is one of the most commonly employed screening tests while assessing the cardiovascular risk. Traditionally and conventionally speaking, lipid profile samples are collected in a fasting state. However, of late and recently, there have been efforts to simplify these sampling procedures by replacing a fasting sample with a non-fasting sample. The people who are in support of this hypothesis have several points in their support. The first and foremost being the total cholesterol levels, the HDL levels, or for that matter, even the total serum non-HDL cholesterol levels, which is a difference of total HDL cholesterol minus HDL cholesterol levels, do not vary much whether the sample is taken in a fasting state or in a non-fasting state. The second point is that most of us individuals do consume about 3 to 4 meals a day and a couple of snacks a day. So to speak, most of us spend most part of our day in a fed state, not in a fasting state. So that is where people think that collecting a non-fasting sample correlate well with the normal human physiology. The third point is that many of the guidelines also of late, including the NCEP and the European Society guidelines on the management of dyslipidemias, do make a point in favor of relying on the non-fasting samples. However, this one part of the story. When we talk about the fasting samples, though the total cholesterol, the HDL cholesterols do not vary much, the LDL cholesterol estimation, the method employed, the Friedewald equation, employs a formula that is for the measurement of the LDL cholesterol is that the total LDL cholesterol is nothing but total cholesterol minus total HDL cholesterol minus the 1/5 product of the total triglyceride levels. Now, the triglyceride levels are known to vary significantly whether the sample is taken in a fasting sample or in a non-fasting state. In fact, the triglyceride levels can start rising soon after a meal, can remain elevated for the next 4 to 5 hours, and can remain elevated for a substantial part of the day following a meal. So, if somebody has huge variations in triglyceride levels, your total LDL levels can also vary accordingly, big time, depending on whether the sample is collected in a fasting state or in a non-fasting state. In fact, when the triglyceride levels are high, and if you employ the Friedewald equation for estimating the LDL-C levels, this may spuriously underestimate the total LDL levels, and in fact, they may misclassify the patients into lower category of the NCP guidelines for decision regarding employing statin therapy to treat the high LDL-C levels. And in fact, this may also deprive many of our patients the benefits of statins while providing them protection against cardiovascular diseases. Of course, you can overcome this issue by employing direct methods of LDL-C estimation, but it is said that this is quite taxing on the health infrastructure as well as the patients who pay for their blood tests. Not just this, it's not just about the fasting versus non-fasting levels of lipid estimation. In fact, there are several other parameters, like you mentioned. A mere change of posture from upright posture to supine position can result in a fall in cholesterol levels by about 10 to 12%. Prolonged tourniquet application for about 3 to 5 minutes can falsely raise the total cholesterol levels by 10 to 15%. It means in winter, the cholesterol tends to be slightly higher as compared to triglycerides, and the opposite is true about triglycerides. Besides this, many medical conditions like hypothyroidism, nephrotic syndrome, and various infections and certain inflammatory conditions also can falsely derange the lipid levels.
Excellent, Dr. Purushottam, you have done an elaborative assessment and when you decide. The problem is that we should also know that almost 80 studies are there now to say that a non-fasting lipid profile can be done, especially in South Asians and Indians, where there is a increased triglycerides, which may not reflect the one what we do fasting may not reflect. So therefore, it is imperative on our part, if you do non-fasting also, it is fine. Next question to Dr. Padma. How often do you do the lipid profile in your clinical practice?
Before answering that question, one more point has to be considered is when should we start? That is what I was thinking. What age we should start screening people for typhoid? Though many of the pediatric societies guidelines are saying that you should screen children also, especially if family history is there. In our other practice, we start screening from 20 years. And then how often? Maybe at the younger age when they don't have any other risk factors, we'll probably do every 5 years. But if they have risk factors, especially if they're diabetics, you should start doing yearly. And once you have found out their dyslipidemia and you have started treatment, till they achieve their goal levels, you are justified in repeating every 4 to 6 weeks. And once they achieve their goal level every 4 to 6 weeks, then probably you can switch to yearly follow-up. That should be a practical approach.
Yes.
And the ACS part, anyway, you are asking Rajesh.
That's an excellent. I think that Dr. Kumar, you have summarized very nicely. That's how we clinically follow. Now, a question to Dr. Rajesh. In post-ACS, most of the time when ACS comes to us, do you think that when a ACS comes, you do a lipid profile, number one? That is first question. Second question is, when should we do it after post-revascularization?
So the management strategy of ACS, in which uploading of statins, high dose of statins has been almost accepted treatment strategy used by most of the interventional cardiologists, and I think my seniors here also agree with it, because the statins is given along with your antiplatelets or anticoagulants in the ER itself, irrespective of the LDL level. So as a part of secondary, because we all know the secondary prevention, statins play important role in preventing further cardiac events in due course of patient's life. Now, as you know, the guidelines specify that the treatment goal is a percentage of the baseline LDL level. Earlier, we used to have a figure like 130 or 160. Now it's a percentage of the basal LDL level. So the question arises is, what is the basal LDL level of the patient? Some people may have it high, some people might have it low. So the question is, after ACS or revascularization, if we have a basal lipid profile done earlier as a part of screening program or a part of a stable cardiac disease management, that can be taken as a baseline LDL level or the lipid profile level, and the treatment can be planned thereof. Once it is done, once we start the high doses statins, which is the norm, then we can measure it about 4 to 12 weeks as per the ACCHA or ESA guidelines. And once the stable level has been reached, the target has been reached with either intermediate or high dose statins, we continue it. But the question is, the patient doesn't have an lipid profile when he presents to an ER with an acute coronary syndrome. To quote the LUNAR study, in which the atorvastatin and rosuvastatin were compared in acute coronary syndrome, there was a subset analysis. They found that what is the lipid profile changes occurring in the patient. So it was found that within 24 hours, there is not much of a change. So if the patient presents to the ER, and if he has within 24 hours of chest pain, a lipid, preferably fasting lipid profile, or as Dr. Purushottam said, even a non-fasting lipid profile can be taken as a baseline. But if it presents after 24 hours, like most of our patients do, as per this LUNAR studies, the sub-analysis of the lipid profile, in which the investigators measured both indirect LDL and direct LDL in a centralized laboratory in US, they found that there was a significant drop in LDL from first day onwards till the fourth day. The direct LDL was the indirect LDL, that feed was 11% more less than the direct LDL. This hypothesis is that increased TG level, change in the circadian rhythm, and also other causes or acute phase reaction to the body. So LDL will be dropped. So what I suggest is, once the patient is in the ER, if he's in first 24 hours, take a sample and take it as a lab value for which you have to target the further treatment plan. If he is already beyond 24 hours, then wait for 4 days. And later, after 4 days, it is said, as per this study, that the stabilization of the pre-event LDL level. So after 4 days or pre-discharge level can be taken. Then the routine guideline management, such as later to 4 to 12 weeks, can be used to guide the further goal targeted therapy.
That you are right, but thinking that you said the acute phase reactions will also have it also changes the lipid profile as such. But if you are not taking a 24 hours, by the time you are already loaded with a high dose of statin, say 80 milligram of atorvastatin, is it correct on our part to start getting a lipid profile done on delta 4 or 5 days when the patient will be already on high dose statin?
So it is said that the statins HMG co-inhibitors doesn't bring down the cholesterol so rapidly to the your treatment strategic level. So it is the acute phase reactants which bring down the LDL or probably the DG is raised during the MI listing. So within 4 days, they return to the baseline LDL without not much of action by the high dose. They would not have acted optimally. High dose statins is used, number one, as the pleiotropic effect of the high dose statins, which is antioxidant or anti-inflammatory and NO favorable, has a part of that treatment, not keeping in the statins has a target in this first high dose statin within first 24 hours. So I think after 4 days, as per the studies which is available, after 4 days it returns to the normal. Probably after 4 days or pre-discharge would be more apt rather than within 4 days. Okay. So that means suppose.
Can I make one point? Quick point. One more important is if you go by the guidelines, they're suggesting that your target LDL is 50% of your baseline. So if somebody who comes with ACS, he has an LDL of 90, then his target LDL should probably be 45. So it's important to know that baseline value in which the patient you have seen first. Many of them will now have had a lipid profile before they got an ACS.
Yes.
So it's good always to know the baseline LDL regardless of when we take the samples.
Yes, that is fine. And as you summarized, at the end of 4 weeks, most of us when we do interventions, at the end of 4 weeks, we call for a first checkup. We should also emphasize on the fact that we should check the lipid profile when they come for a first review at the end of 1 month. Because ECES guidelines says that 4 to 6 weeks, we have to repeat a lipid profile to know whether his LDL has come down more than 50%. How fast it has come down and how much it has come. So therefore, we may have to, when they come for a first review, probably we may have to do. The next question to Dr. Purushottam, statins and non-lipid role. A lot of non-lipid role is there for statins. What is your inference?
Yes. Many of the beneficial effects imparted by the statins are said to be their prime property, that is their lipid lowering ability. These effects are said to be clearly independent of their LDL lowering abilities. These are broadly classified as the pleiotropic effects of statins. Now, pleiotropic effects are the other actions of a particular drug than the ones for which this molecule is actually developed. These pleiotropic effects can be undesirable when they result in side effects. They can be neutral when they have no effect, or as in case of statins, they can be beneficial. And fortunately so, for us, statins do induce a lot of beneficial pleiotropic effects. As we all know and understand, atherosclerosis is a constant inflammatory disease. Statins are known to have a calming influence on the very pathogenic mechanism of atherosclerotic process, and thus bring down the inflammatory component of the plaques. And they do reduce the hsCRP levels to a great extent. They do inhibit the inflammatory component of a plaque. They do induce apoptosis in smooth muscle cells in the vascular intima and media, thereby having the inhibitory effect on the smooth muscle hyperplasia. They promote collagen content of atherosclerotic plaque, thereby promoting plaque stabilization. And some of these effects do, in fact, some of these pleiotropic benefits, the varying ability of a statin to induce these pleiotropic benefits, plus the differing efficacy of statins in their ability to lower the cholesterol percentage, finally determine which statin scores over the other and which statin gives way for the next statin, which is more potent, more safer, and impart better pleiotropic benefits. In fact, these pleiotropic benefits have been made use of and extrapolated while extending statins use beyond the cardiovascular diseases and while extending their use to various other modalities like in treatment of Alzheimer's dementia, Alzheimer's disease, and various other forms of dementia, in treatment of multiple sclerosis, some forms of cancer, and while during the treatment of osteoporosis also.
Yes, I think you have summarized very nicely. Basically, we give high dose of statin for more neotropic effect, and it has almost all the diseases it has been shown that it is effective now. So, Dr. Padmakumar, which component of lipid profile we concentrate? Like when you do it, like we have lipid profile. So, do you give subfractions of it? Do you give any importance for LDL HDL ratio and those things?
I still go because if you go by the guidelines are giving concrete figures based on two values. One, the value of LDL, and second, the value of non-HDL cholesterol, as Dr. Purushottam was saying. LDL is the first thing that we should concentrate on. You bring it down to the target. But we know that people who have ideal LDL levels also tend to develop atherosclerosis. That means there are certain fractions with certain lipid components which are contributing to atherosclerosis, which are not detected or reflected in your LDL concentrations. There comes the importance of non-HDL cholesterol. Like you may think, why? When if LDL is the harmful one, then why should a non-HDL cholesterol be an indicator, probably more important indicator than LDL in that group? That is because there are certain fractions of LDL which are more harmful, like oxidized LDL, small dense LDL, and even the lipoprotein small a, which may not be reflected well in your LDL concentrations. But once you have a non-HDL cholesterol, it is a non-HDL cholesterol is a marker of the bad LDL cholesterol also. Means it is a marker of the poor company. That if you have people who have a high non-HDL cholesterol, they tend to have higher small dense LDL, small oxidized LDL. So I basically first concentrate on LDL, and I always look what the non-HDL cholesterol is. And a triglyceride, I am not bothered much unless it is above 400, because of the risk of other problems like pancreatitis. And in 150 to 400 range, though many patients are worried about, I am not much worried about if your non-HDL cholesterol we have brought into reasonable range. So it is always best to have a triglyceride less than 150. The 150 to 400 range, don't look at absolute value of triglyceride, you concentrate on non-HDL cholesterol and bring it to the range that we want.
What about the LDL-HDL ratio? Do you think any importance is due to that?
Yes, definitely. When you say that you have an protective role of HDL and LDL having a harmful role, naturally, logically, it means if you lower the LDL-HDL ratio, you are at a lower risk of atherosclerosis. But there is only an indirect way of telling that you should have a low LDL and low non-HDL cholesterol.
Dr. Rajesh, how much importance is given to non-HDL? Already he was briefing.
I think Dr. Padmakumar sir has already told the importance of non-HDL level. So non-HDL level, if we see, sir, ideally in the traditional studies, we have seen that LDL was concentrated upon and told to be the role marker for atherogenic diseases in the heart. But we should not forget that VLDL and IHDL are also the different forms of LDL.
Yes.
LDL is the metabolic process, the end product of all this thing, all the three atherogenic molecules. Whereas we all know that HDL is good cholesterol. So it is like a Ravana Sena, Ravana, Kumbhakarna, Indrajit, Vibhishana. So we minus Vibhishana, we get all the bad particles. But concentration is only on Ravana.
So you mean Vibhishana
is good HDL which has come down. So if you take this load, so especially in patients who have a low history of ASCVD, in which the LDL level is near normal or slightly elevated, in that cases, I look upon non-HDL and see the value. If it's more than 130 or 140 mg per dl, I put him on statins. Second thing is, when there is at a given level of LDL, elevated HDL also marks as the marker of coronary artery disease. Hence, the HDL, non-HDL level has also been looked upon and targeted upon on treatment of. This slide shows that at a given level of LDL, the non-HDL level markedly increases the chance of acute coronary syndrome. Clearly shows that association. So I think non-HDL level has to be given as the same pedestal as LDL level, especially in very mildly raised LDL, which doesn't, or LDL in which level if the CVD risk ratio is more than 7.5 to 20.
I thought we forgot about the beneficial effects of Vibhishana. Isn't it? HDL is not
coming. So now, Dr. Purushottam, What about high triglyceride and low HDL? This is a for Indians, but
Yes, this is typically known as the Indian dyslipidemia. We Indians are different, and so are our lipid profile. Unlike the Western population, most of the Indian population, as well as the South Asian migrant population, tend to have a slightly different pattern in their lipid profile. We result in premature putting us at risk of development of premature cardiovascular disease. While doing so, they also put us at risk of development of premature type 2 diabetes mellitus, and we do show tendency to develop this metabolic syndrome. And lastly, before I conclude, in fact, many of us tend to believe that these kind of dyslipidemias that we develop are of added
a person who has significant atherosclerotic disease, let's say a person comes to me with coronary artery disease, proven coronary artery disease, and target is LDL as 55. A person who has a moderate risk of coronary artery disease, like any diabetic coming to me for a cardiac evaluation, I tell him that his target LDL is not what is given in the lab report. His target LDL is 70 because he is at moderate risk of coronary artery disease. Whereas a person who is normal, who is coming to me and asking me what should be your ideal LDL, I probably will tell him that somewhere around 110, maybe 100, 110. We are strict 100, otherwise 110. But there is an upcoming recommendation for people with polyvascular disease. We see some people who have vascular disease elsewhere, like you have coronary artery disease, stroke risk, you have peripheral vascular disease, renal artery. So if you have polyvascular disease, I keep my target even stricter and I tell them that around 30.
So I think suppose if you have a patient who has been treated with a revascularized either CABG or PTC, but that person again comes with another ACS.
Again, probably I will be much more strict in the target.
You have to be very strict, because probably in that if somebody is maintaining 70 or something, you should bring it below 55.
And there comes the importance of that 50% cutoff from the baseline also.
That also
comes.
So these are the various guidelines which have come now, especially ESC and the Lipid Association of Guidelines, they are very clearly telling that less than 55 milligram per deciliter for very high risk patients. So there are newer, all these terms are used, very fancy terms like high is bad, average is not good, lower is better, even lower is even better, lowest is the best. Like these are all the new words which have been coined to make it very attractive. So just for us to concentrate that the LDL has to be brought down to 50-55, especially in Lipid Association of India, they want 50 only, like at least the European Society, they say 55. And especially when they come with the second event post, I think they should look into that and seriously think of adding, suppose if we are not able to achieve the maximum tolerable dose of statin, we may have to add ezetimibe or PCSK9. That we will be discussing later.
One more point I was telling is people are happy keeping an LDL goal of 55 in a patient comes to CAD. But if you have atherosclerotic disease anywhere else also, like a person who comes with peripheral vascular disease or a person with stroke also, we should keep the same goal.
Yes, correct. Absolutely correct. Yes. Now, we have various guidelines which have come about the intensity of lipid lowering things, and there is a role for PCSK9 or ezetimibe, which we will be discussing later. So, the latest guidelines have said that suppose if you have an LDL-C goal is not achieved at the end of 4 to 6 weeks of maximally tolerated statin dose, then we should add ezetimibe to that. So, nowadays we are adding more of ezetimibe into in our clinical practice. So now we have new targets and new challenges. The challenges are very easy to tell, as Dr. Padmakumar said that guidelines are keeping on coming and changing. It is very difficult to practice it, to get the guideline level LDL in our practice. So how low should we go? That's what we discussed. And anything you want to add to that?
No, I think that how low is based on that data from animals. If you the famous this thing that chimpanzees which are resistant to atherosclerosis has the lowest LDL. So we have to go evolutionary wise, you have to go back and be like chimpanzees with their lipid and get it below as low as possible.
But how low can we get is a bigger problem. I think in our clinical practice, it's not that easy to get an LDL below 55. Most of the patients, some patients will respond, some patients do not respond. I've seen in our practice also 80 milligram of atorvastatin or 40 milligram of rosuvastatin, add ezetimibe to that also, still the LDL over around 100 and above. Of course, there will be a role for PCSK9.
I think that's the dilemma we will have when PCSK9 inhibitors become cheaper. Now we have only 2 drugs to give, like statins and ezetimibe. Yes. So you give maximum tolerated dose and stop that. And nobody can afford PCSK9 inhibitors.
So therefore, we just do add ezetimibe and we forget that.
Once it comes down, then we have this question in mind.
Do we safely achieve the targets? Do you think that many of the patients will tolerate this combination or the higher dose of statin in our clinical practice? Purushottam, you want to add something?
In fact, many of the untoward effects attributed to statins are rather overdone. In fact, most people do achieve the targets in the given. But at the same time, my concern is that do we have to rely on 40 to 80 milligram of atorvastatin or 40 milligram rosuvastatin to achieve these levels? In fact, we see many of our Indian patients achieving these levels with lesser doses of statins. That is us. So I don't think one recommendation fits all. I think it's safe to individualize it or customize it to our needs.
In fact, there is a study which says that rosuvastatin 40 milligram among the Indians is not very good. True. There is a study on that also, because they have, in Westerners, they use 40 milligram of rosuvastatin, but in the Indian setup, it is we may have to monitor because other side effects has to be monitored. So now going to this is another important slide wherein which we have to, the emphasis on LDL-C goal attainment and how rapidly LDL-C lowering effect is also important. And another important thing is the duration of LDL-C lowering therapy. What we find is that suppose you put a patient on 40 milligram of atorvastatin, you got a LDL around 50-55. But if they go to a physician, for a local physician, sometimes they say that your cholesterol has come down very drastically you please reduce the lipid profile, this one statin to 20 mg. This is commonly we find in our practice, but we want to highlight today that it is not only the rapid lowering of LDL-C or the low LDL-C attainment, but it is a duration of LDL-C. It has been clearly shown that if you keep the LDL less than 50-55 for longer duration, the coronary events or whatever is the major adverse cardiac events or any of the ACS events can also be reduced. That's what we want to highlight. And then we have discussed the LDL alone is the culprit. So we have a beautiful Framingham study which shows the 26-year follow. It's LDL with the total cholesterol. LDL 35% of the CHD occurs in patients with less than 200 total cholesterol also. So, but there's a long linear relationship between LDL-C and the relative risk for CHD also. Now, Dr. Purushottam, what about ezetimibe? Do you add ezetimibe in your practice?
The question, to answer your question, I don't routinely add ezetimibe in all my patients. Basically, to speak a few words about ezetimibe, basically that exerts its effect by a different mechanism. It reduces the gastrointestinal cholesterol absorption. In a meta-analysis on ezetimibe, it was found that when ezetimibe was added routinely to the pre-existing statin therapy, it did not have an impact on the overall mortality or the cardiovascular mortality, although it did result in a reduction of MI and stroke. In fact, another study also revealed that it had a beneficial effect in the form of bringing down the Lp(a) levels also, but the extent to which it brings it down did not result in any clinically distinct results. So, ezetimibe, of course, is a reserve drug to be added to the existing statin therapy when we fail to achieve adequate LDL-C reduction despite the maximum tolerated dosages given. And it also can be given in various other forms of dyslipidemias like primary hyperlipidemia, mixed dyslipidemias in combination with statins and fenofibrate, and in some of the cases like familiar hyperlipidemias and other instances. I think this drug can be of use.
I think particularly if they are diabetic, this is going to be very helpful because of the gene expression which is there in diabetic group. So I think in diabetic patient, if you add ezetimibe to the existing lipid statin, you can get around 16 to 24% reduction of LDL. But I think there is one more group of patients which we find in our practice that sometimes if they cannot tolerate the higher dose of say 80 milligram of atorvastatin, you can add ezetimibe to 40 milligram of statin also, that they will tolerate better, but especially if they are diabetic. The next question is to Dr. Kumar. How often you use PCSK9 inhibitor? We already discussed that.
But instead of saying that how often, I will say when to use. Probably you should use it if you are not given a good dose of statins, maximum and ezetimibe, and still you are away from the target. And of course, if the patient can afford. But one thing is I want to emphasize is the more and more data is coming that PCSK9 inhibitors not only reduce your lipids, they reduce your MACE. And trials are happening in even acute coronary syndrome. Yes. People who are having ACS revascularized or non-revascularized or put on PCSK9 inhibitors, their events on follow-up are coming down. Okay. So once that more data comes in, then the role of use may increase. And also, I have used in at least one or two patients who are having familiar dyslipidemias, where lipids are just laughing at the statins that you give, and LDL is refusing to fall, and where there's a motivation because their children, parents are willing to spend. I have used in this thing. And one patient I can remember who we had put 5 stents, 6 stents, and we gave statin, and 1 week later he comes and says, I can't tolerate statin myalgia. There we had this. It's an affording person, so I put him on PCSK9 inhibitors. But I should say that later I could restart statin at lower dose, slowly go up, and he is tolerating it, and now I have withdrawn PCSK9 inhibitor also.
Yes, I think that's very nice. I think Rajesh, how do you see that the side effects of statins in your clinical practice, necessitating reduction of dose or even stopping it? Do you think that you find it very frequently or infrequently?
Sir, as Dr. Purushottam was telling, our Indian population are having a fairly good control of LDL with maybe low dose or intermediate dose of statins. So I think God has been kind to us. So He has given the South Asians a higher risk of coronary artery disease. He has also made us statin sensitive, having a protective mechanism. In my clinical practice, most of the time what we see is at the onset of the acute coronary syndrome or an acute coronary revascularization, we put high dose of statins. And at the end of 4 to 6 weeks, I have seen certain patients with bit of myalgia, especially shoulder girdle or the hip girdle pains. And I routinely measure their CK level. It is not raised, so there is no myolysis. It's just the myalgia secondary to the high dose of statins. Second, there might be a marginal rise of liver enzymes, which I would, as you rightly said, at the end of 4 weeks, we should ask them to come back with the lipid profile. I also ask them to come with an LFT most of the time. And I say a marginal rise, not necessitating.
Probably you have to take the baseline. You can make it up to 3 times the basic level.
Correct.
Correct. SGOT.
So once we do this, once we as I said, our patients, most of them maintain it intermediate at a 20 level of 20 milligram of rosuvastatin or 40 milligram of atorvastatin. At that level, I have seen most of them don't see any major side effects which is listed in the guidelines or the textbooks. So far I have not stopped any patients statins calling for the due to the side effects of statins.
So, but we have to mention about the nocebo effect. Just like drug having placebo effect, people say that many of the myalgias of statin are nocebo effect. You put on a trial with a control drug which is not a statin, they may come back with equal frequency of myalgia with those drug also. So the nocebo effect also we have to know.
But I think we have to keep it in mind that the side effects of statin, keep it in our mind in a clinical practice. But if it appears, then we should actually withdraw or reduce the dose.
We want to discuss statin and diabetes also.
I think Dr. Purushottam, do you feel all statins are the same? Do you prefer in your clinical practice?
Yeah, the clear answer is they are not. In fact, if they were same, I don't think there would have been so many molecules in the market today. Many of these statins are quite different in the way they exert their effects. I think they differ in terms of pharmacokinetics, their cholesterol lowering abilities, their ability to induce the pleiotropic benefits, plus lastly the safety profile of these statins.
Yeah.
When we talk of the pharmacokinetics, let me briefly touch upon the atorvastatin and simvastatin. Atorvastatin is a drug which gets absorbed rather quickly from the gastrointestinal tract, has a long duration of action, has a therapeutic half-life of about 4 to 6 hours, and the lipid lowering ability of a single dose can last for 10 to 12 hours. In comparison to this, simvastatin, which is slowly falling out of favor, is a kind of a prodrug. Once ingested, it has to be converted to its active metabolite, simvastatin acid, and that's when it starts exerting its anti-cholesterol effects. Has a short half-life, and possibly the duration of action also is relatively shorter, and perhaps this is one of the reasons why it falls short in comparison with atorvastatin. Secondly, regarding the lipid lowering ability, has been clearly proven by various trials like be it the PROVE-IT or RIVERS studies, wherein atorvastatin proved superior to provastatin in PROVE-IT trial, while in reversal trial also, atorvastatin was considered distinctly superior. So in the current day clinical practice, I rather stick to either atorvastatin or rosuvastatin, considering their efficacy as well as the safety profile.
Yeah, thank you, Dr. Purushottam. I think this we have discussed. I think the maximum dose stage in the practice. And you add a phenofibrate, Dr. Rajesh, in your clinical practice.
Phenofibrate is basically a drug used to treat the hypertriglyceridemia. It has been in ECC EHA guidelines and even European Society. they classified these drugs as a non-LDL lowering drug. So the guideline says if you are not achieved the target with statins, add estimate or PCSK inhibitors. Fenofibrate finds no role in that. Coming to said that if the patient is having a primary hypertriglyceridemia, that is the elevated triglyceride more than 250 or 300, first we have to rule out diabetes, is liver or kidney disease or hypothyroidism. If these are there, they have to be treated, and probably triglyceride treatments come secondary to that. If the patient has primary hypertriglyceridemia with no very low risk of ASCVD risk or no family history, then if it's more than 400 or something, as Sir said, I put him on fenofibrate as a primary treatment and then monitor as such. But if you see in the patients with ASCVD risk or having a coronary artery disease and on statins, if you see the sub-study of the Accord study, in which they have the lipid subset of the Accord study, they have measured the lipid levels of the patients, and they have put them on statins plus fenofibrate and statins with a placebo. In that, it was found that the effects of fenofibrate ruled arms was only beneficial in patients, males especially, having a HDL of lower than 34 and the triglyceride more than 204, and it is marginally beneficial in reducing the ASCVD risk and the statin levels. On the contrary, in females, there were some adverse events of the raised liver enzymes and the hepatic necrosis and other things. So fenofibrate per se in achieving the goal has, I feel there is no role, but it can be added in small subset of patients. It's less than 16% of the total population what we see, which is having a raised triglyceride with LDL level, which can be benefited. So if the patient has already a low HDL and a high triglyceride, a male patient, then there is no harm in adding once we adequately treat with statins or estimate and accessory PCSK once it is available, affordable.
Yeah. I think we should also keep in mind that fenofibrate increases the creatinine. In CKD patients should be careful. And there are some reports saying that it increases DVTP, fenofibrate, thromboembolic episodes, and INR also when we add warfarin. So these things should be kept in mind. I think we are short of time, but we will hurriedly go for niacin role shortly. Very short, brief, Dr.
Yes.
Use it in your practice?
No, I don't use it. I haven't used it. Used it on a single occasion purely because of its safety profile or the lack of it. It's a drug which substantially increases HDL levels while bringing down the triglyceride levels modestly and the cholesterol levels modestly. But some of the side effects mentioned, like frequent flushing, acanthosis nigricans, hyperglycemia, hyperuricemia, are quite frequently encountered. In fact, there are reports that daily use of aspirin concomitantly can mitigate the risk of flushing to an extent, but it's not entirely foolproof. So in spite of the fact that niacin has been proven to have excellent protection when used in association with statins, in fact, it is proven to retard the progression of angiographically proven coronary artery disease and thus provide cardiovascular benefits. It still remains an investigational drug.
Yeah, short, Dr. Padma Kumar, omega-3 fatty acids.
I use seldom. I have not initiated. Mainly the indication comes with parallel to the indication of fenofibrate. It is very widely available and more tolerated. So I have seldom initiated, except for a couple of patients who have come from abroad who are on this drug. I have not withdrawn them. But one caution: this drug studies have been contradictory. Some have shown benefit. Always use it as an add-on drug to statin if you are using. And remember that they have an increased incidence of atrial fibrillation or flutter with this fish oil.
Yes.
And also some bleeding tendency also.
We also don't use it.
And many people say that if you take 2 fish servings a week, it is as good as the 4 gram per day fish oil tablet that you eat.
And this, I think, we discussed. Despite statin being high dose, the CV events can occur. We infer, already we discussed, Dr. Rajesh, that because of the residual risk which is there, and we should also look at it not only LDL, non-HDL also plays a role in that. Especially if you look at this, now both in this patient, the total cholesterol is same and LDL-C is same, but look at the triglyceride and HDL. The one which is on the right side, will have more event because they have small dense LDL compared to the cholesterol esters which is present in the left side. So last small point, reversal study. You want to highlight?
That is whether statins reverse atherosclerosis. But if you go through reversal study in detail, when I read through it, what I realized was that if high dose statins produce some modest fall in lipid volume versus moderate dose statins, which don't prevent the slow increase in your atheroma. So basically, the study gives the basis for recommending high dose statins, in which 80 milligram atorvastatin was used in the study, compared with 40 milligram of pravastatin. So it gives a proof of the concept that if you use high dose statin, a subset of patients may have regression of atherosclerosis. For every 10% drop in LDL, your plus atheroma volume may come down by 1%. So it's not that a 90% block will become 30% or something. It will stabilize the plaque and bring down by a few percentage if you use high dose. It's an intravascular ultrasound stress.
Small briefly about CRP and LPA because short of time.
Sir, we know that HSCRP is always inflammatory marker. So elevated, when we see at the coronary artery disease profile, what has an interventional cardiologist or a general physician's point of view, the vulnerability of plaque is important. So elevated HSCRP more than 2 mg per dl shows that the plaque is not stable and contains inflammatory reactions in it and tend to have a coronary event in near future. So the elevated HSCRP gains significance from this point of view. And second thing is lipoprotein small a is again Ramanasena as a part of the bad cholesterol. So estimating in especially patients who have got a low risk of ASCVD, puts them in it's a risk enhancing factor. Presence of more than 50 mg per dl put them in a higher bracket for the risk of ASCVD and requires treatment for that. Recently, I think the Canadian Society for Cardiology, they have put a study of one drug which targets lipoprotein small a. It's been called ADM 680. The results are yet to come. So I think these two are important in the management of lipids.
Yeah.
I'm okay as long as they all belong to Ramanasena. I'll be a concerned man when they become a part of Shiv Sena.
So I think we had a very nice discussion. To conclude,
we don't say Shiv Sena is LDL and Congress is lipoprotein small a.
So conclusion is that atherosclerosis is equal to CVD. We know that. We have to target LDL, but don't forget the non-HDL and add histamine in your practice, and if patient can afford, PCSK9 also plays a major role. And this is Braunwald's corner, which he also emphasized that substantial evidence for less than 55 LDL has been shown. So thank you very much, and we had a lively discussion. And I thank my panelists, Dr. Purushottam, Dr. Padma Kumar, and Dr. Rajesh. So we're running 10 minutes. 5 minutes. 5 minutes.
Thank you. That was a wonderful panel discussion. I hope all of you have gathered many informations. Moving next, we have Dr. John, all the way from Canada. We'll be talking on dual pathway inhibition to prevent atherosclerotic vascular events 2022 update. To chair this session, we have with us Dr. Suresh Patel as well as Dr. Ashraf from Kannur. Yes, over to Dr. Ashraf, the chairpersons. Dr. Ashraf?
Hello.
So we'll start the session.
Hello.
Yes, sir, you are audible, sir.
I am audible. Hello.
Yes.
Good morning, everyone. It is my pleasure to be part of this morning symposium. Already we are lagging behind the time. Without wasting much of our time, I will call upon Dr. John Akelboom from Canada. He is actually the principal investigator for our COMPASS trial. As we all know, atherosclerosis is one of the cornerstone when the major problem for the acute coronary syndrome and various other events, vascular events that take place. All along, antiplatelets were the one which were being used for treatment of atherosclerosis. We were not using anticoagulants because of the various side effects earlier. Now with the introduction of NOAC, the dual pathway inhibition has become a long way in our clinical practice. And we have Dr. John to speak on this. He is a better person. He's been the principal investigator of COMPASS trial, and we will hear from him and his views of dual pathway inhibition of atherosclerosis. Dr. John?
Yes, sir. Thank you.
Yeah, go ahead.
Thank you very much for inviting me to present at the eSpectrum 2022 meeting. I'm delighted to share with you the latest information on dual pathway inhibition to prevent atherothrombotic vascular events. And I will be showing you some data that are not yet published, but which further reinforce the efficacy and safety of this remarkable new therapy for cardiovascular prevention. I've divided my talk into three parts. The first part, I will define with you the meaning of acute and chronic atherothrombotic disease. Second, I will turn to the evidence from the randomized trials. And finally, I will discuss with you some of the clinical applications, the best way to apply this therapy in clinical practice. Now, right at the outset, it's important to be clear that dual pathway inhibition and indeed antithrombotic therapy is only one component of cardiovascular prevention. So whilst my focus will be on antithrombotic therapy, we mustn't forget that lifestyle changes and other medical therapies are equally fundamental to protecting our patients from further cardiovascular events. Dual pathway inhibition essentially involves combining an anticoagulant with an antiplatelet drug. And historically, that was done with warfarin and aspirin following myocardial infarction. that therapy was since replaced by dual antiplatelet therapy, and we haven't used dual pathway inhibition with warfarin and aspirin for any other indications routinely, except perhaps in patients with mechanical heart valves. But here, when we talk about dual pathway inhibition, I'm referring to the combination of low-dose rivaroxaban and low-dose aspirin, the only combination that has been extensively tested in acute and chronic coronary artery disease or peripheral artery disease, and that has been overwhelmingly shown to be effective for preventing cardiovascular events and saving lives. At the acute end of the spectrum of disease, of course, we have patients with a recent myocardial infarction, those who undergo percutaneous coronary intervention and stenting, as well as those with peripheral artery disease who are recently revascularized. At the other end of the spectrum, the patients with chronic atherosclerotic vascular disease. These are people who are 6 or 12 months or longer post-acute disease. They may have chronic stable angina. They may be angina-free. They may have intermittent claudication. They may be leg pain-free, but they have underlying atherosclerosis, which is progressive, which is chronic, and which puts them at risk of subsequent further events. The trials that have tested dual pathway inhibition in the acute phase include the Atlas ACS trial and the Voyager PAD trial. These two trials showed very consistent benefits of adding low-dose rivaroxaban in recently revascularized or recent acute patients. Towards the chronic end of the spectrum, we have a large data set from the COMPASS trial, which is now complemented by an additional up to 3 years of follow-up in the long-term open label extension component of this trial. And those are the new data that I'll be sharing with you. Well, to whet your appetite for the story, let's present a brief case. Mr. CVD. He's 67. He has typical cardiovascular risk factors, dyslipidemia, diabetes, hypertension. He stopped smoking at the time of his myocardial infarction 1 year ago. He also has chronic kidney disease, and his vascular history, in addition to the myocardial infarction with primary PCI and stenting, he has intermittent claudication and has previously undergone a left femoral artery angioplasty. Now, of course, lifestyle change and other medical therapies are critical, but the question that I'm posing now to you is, what's the optimal long-term antithrombotic strategy? He's on aspirin and ticagrelor, or you could assume he's on dual antiplatelet therapy. So he could be on aspirin and clopidogrel, but in this case, he's on aspirin and ticagrelor. Well, with that case, let's turn to the evidence. And I've already described to you that the Voyager and Atlas trials showed a clear benefit of adding a low dose of rivaroxaban to aspirin following a recent revascularization for acute event. And here are the data for Voyager: 6,564 patients, a 1/6 or 1/7 reduction in major adverse cardiovascular events. If this treatment is started promptly following peripheral arterial revascularization and started on a background of routine antiplatelet therapy. And about half these people received clopidogrel and aspirin, the other half received aspirin alone. The benefits were absolutely consistent, irrespective of whether one antiplatelet or 2 antiplatelet drugs were used. The second trial, the Atlas trial, this is the acute coronary syndrome patient study, a larger study of 14,000 or so patients who received low-dose rivaroxaban, either 2.5 twice a day or 5 twice a day, on a background, again, of antiplatelet therapy. But in this case, almost all patients received dual antiplatelet therapy. Once again, about a 1/6 or 1/7 risk reduction in major adverse cardiovascular events, and notably, the 2.5 milligram dose also produced a mortality benefit. And this beautifully sets the scene for the COMPASS and the COMPASS long-term open label extension. The design is shown here. COMPASS itself involved 27,395 patients. You'll notice that patients were randomized to one of 3 treatment groups: rivaroxaban 2.5 plus aspirin, rivaroxaban 5 milligrams twice a day, or aspirin. At the end of the trial, having shown that the dual pathway therapy with the combination was highly effective and saved lives, all patients who were still taking study drug at the end of COMPASS were offered the opportunity of continuing treatment with the combination of rivaroxaban and aspirin. And 12,964 patients participated in this long-term open label extension. The maximum follow-up during the randomized treatment was almost 4 years. And with the Ldl component, we achieved an additional maximum of 3.3 years. So here we're getting very long-term experience with low-dose rivaroxaban plus aspirin. The COMPASS results are well known. There was a 24% reduction in major adverse cardiovascular events, including consistent reductions in CV death, in stroke, and in MI. And one of the most remarkable findings was the reduction in stroke. Now, it's common for cardiologists to focus their attention on coronary events at the expense of disregarding, dare I say, other vascular events. And that makes sense because cardiologists deal with cardiac problems. But remember that for every 3 strokes, for every 2, I should say, for every 3 myocardial infarctions, there are 2 strokes in the COMPASS trial. So stroke is actually a very common event in these patients. And if we added low-dose rivaroxaban to aspirin, we achieved a 50% reduction, an almost 50% reduction in ischemic stroke, a small numerical excess of hemorrhagic stroke, but not statistically significant. So this is dramatic result number 1. I'm going to show you 2 other key results. Dramatic result number 2, a reduction in major adverse limb events. Now this includes amputation, reduced by 50%. So that's the second very impressive result. And then to top it all off, there was an 18% reduction in mortality. Now there are very few treatments in cardiovascular medicine that can reduce stroke, amputation, and save lives. And remarkably, in the COMPASS experience, this trifecta of benefits was achieved. And you'll recall that the mortality reduction is no surprise because it was also seen in the Atlas trial. The plot shown here is the effect of treatment of adding rivaroxaban to aspirin on mortality. The middle line is the hazard ratio, and you'll notice that it is below 1 at all times. The line above it and the line below it are the confidence intervals. And so over time, as deaths accrue, this confidence interval becomes tighter and tighter. You become more and more confident in the result. But you will notice that even in the first 3 months, there were fewer deaths with rivaroxaban. So remarkable trifecta of results. Now, what about people who were 6 months or a year or 2 years or 5 years or even 10 years following a PCI? And the data have been separately published. These are also very impressive results. On the left-hand panel on the screen, you will notice the results for CV death, stroke, or MI. The middle line is the hazard ratio estimate. The blue area is the 95% confidence interval. And you will notice on the x-axis, these are patients who are up to 10 years post-PCI. And it doesn't matter where we started the treatment, whether it's in the first year, the 5th year, or the 10th year, we've got a very consistent 1/4 reduction in MACE. And on the right-hand panel, we've got a very consistent and of similar magnitude, about a 1/4 reduction in mortality. So if you've got a patient 1 year post-PCI and they're at high risk, and you put them on a low dose of rivaroxaban, you're going to get substantial survival benefits. Is there a downside? Absolutely. There is an increase in bleeding. Here are the major bleeding data by site. On the left-hand side of this graph, you see gastrointestinal bleeding, which is doubled approximately from about 0.8 to 1.6%. Still in absolute terms, a rather modest effect. None of the other sites of bleeding were increased except the skin. And you will say, why was skin bleeding increased? Well, we don't know exactly, but we collected all types of minor skin bleeds, including injection site bleeding that may occur in a patient who has diabetes. But none of the other sites were significantly increased. GI bleeding occurred almost entirely in the first year. And although it's classified as major, here is the information on how the bleeds were managed. You will see of the 288 major bleeds in this population of patients taking rivaroxaban and aspirin, only about 1/3, 30%, needed a red cell transfusion. Similar to aspirin, only about 1/4 to 1/3 of aspirin group needed red cell transfusion. The other 2/3 didn't even require a transfusion. Very little use of other blood products such as platelets or coagulation factors. And this should be very reassuring. Remember, no excess of intracranial bleeding, no excess of fatal bleeding, no excess of critical organ bleeding, just GI bleeding in the first year, low absolute event rates, and readily manageable. The treatments continued to accrue benefit over time. And you see the 3 upper panels separating curves for CV death, stroke, MI. The lower panels, in contrast, parallel curves for symptomatic bleeding into a critical organ, not significantly increased. Parallel curves for fatal bleeding, not significantly increased. And if we put those together, it's obvious that we're seeing accumulation of an increasing net clinical benefit. Now, there is one important recent piece of information which reinforces the truth that this treatment should be continued indefinitely without stopping. Because it's okay to stop the treatment for a week or even a month temporarily for some intervening process. But if you stop for a year, and this is shown in people who stop treatment at the end of the study and switch to aspirin, people who were originally on rivaroxaban plus aspirin, who are now on aspirin, you will see that they have higher event rates than people who were previously on aspirin and just stayed on aspirin. In other words, you lose the protection. It's like you flip the chart. On the left-hand side, it's for CV death, MI, or stroke, and it's not significant. But on the right-hand side, it's for stroke. And here it is significant. So what happens is during treatment, you get a benefit. And then if you stop treatment, you actually flip the curves and you get harm. Very important data. Well, to summarize the data that I've shown you in COMPASS, rivaroxaban plus aspirin is the first therapy since aspirin to achieve a mortality benefit when used long-term. The first antithrombotic therapy since aspirin. We didn't see it with clopidogrel, and we've never seen it with dual antiplatelet therapy. Not with aspirin and clopidogrel, not with aspirin and ticagrelor, not with aspirin and prasugrel, only with rivaroxaban plus aspirin and with aspirin alone. Furthermore, the magnitude of the MACE benefit, a 24% risk reduction, is rather impressive here. Well, what about the long-term open label extension? And of course, everyone during the long-term open label extension was receiving the same treatment. So there is no comparator group. But if you look under the Ldl column in the middle of this table, at the top you see 353 primary events, an event rate of 2.35 per 100 patient years. And then on the right-hand column, during COMPASS, there were 379 events, and the event rate was 2.18 per 100 patient years. So similar rates for CV death, stroke, MI, similar rates for mortality, similar low rates for stroke, similar rates for MI, similar rates for severe limb ischemia. The only thing that was substantially different was that hospitalizations were substantially lower during Ldl than COMPASS. So if we extend by up to 3 years in Ldl, excellent outcome data. For bleeding, as you might expect, because bleeding is front-loaded, the bleeding event rates during Ldl were very consistently a lot lower than the bleeding event rates during COMPASS when people were taking the combination of rivaroxaban and aspirin. And you can see that at the top of the chart, it's major modified ISTH bleeding, the event rate 1.01 versus 1.67. If you scan down and look at gastrointestinal bleeding, 0.3 versus 0.8, so less than half seen in COMPASS, and minor bleeding less than half seen in COMPASS. So very reassuring long-term treatment data. I want to spend the last couple of minutes and look at then how do we apply this information in clinical practice. And it's actually very straightforward. We know that dual pathway inhibition provides a clear net benefit and provides a mortality benefit. The benefits increase over time, and the biggest benefits are in those at high risk. So what do I need to know to apply this therapy? What do you need to know? You need to know who is at highest risk. That has been extensively documented in a series of papers. I've put some of the references at the bottom of this slide, but I can summarize it very simply. We can use clinical characteristics to define the high-risk group, and there are 4 key groups. The polyvascular patient, that is a patient who has coronary and peripheral artery disease, the patient with mild or moderate heart failure, the patient with chronic kidney disease, and the patient with diabetes. I don't have time to show you all the data. 2 groups that are of particular importance to you are polyvascular disease. There's a lot of that in India, and diabetes is obviously rampant in India. So what did we find in those 2 situations? This graph comes from a 2019 paper. I focus your attention on the blue box on the left. You will see in that blue box 1 VB, 1 vascular bed. And then beside that, you will see 2+ vascular beds. So the 2+ is the polyvascular patient. The 3 bars, blue, orange, and gray, represent the absolute risk reduction, the absolute number of events prevented in first year, the second year, and up to 30 months. And you will notice that the bars for 2+ vascular beds are much higher than the bars for 1 vascular bed. In fact, of all of these high-risk situations, having polyvascular disease identifies the patients at very highest risk who derive the greatest benefit of treatment. In the columns adjacent to the blue box, you will see heart failure, kidney disease, and diabetes. In each case, they have large benefits and larger benefits than the overall population, which is on the extreme right. Now, what about diabetes? This is a lovely paper from 2020 in Circulation, led by Deepak Bhatt from Boston. In the left-hand panel is the effect of treatment with rivaroxaban plus aspirin versus aspirin. In the dotted line, it's the treatment effect in patients with diabetes. And in the solid line, it's the treatment effect of patients without diabetes. So event rates are higher in diabetes. Absolute benefits are greater in diabetes. On the right-hand panel, the same data, but this time for mortality, higher rates in diabetes, and bigger absolute benefits in diabetes. So in those 2 conditions, it's clear that low-dose rivaroxaban, that is in polyvascular and diabetes, it's clear that a combination provides even larger benefits than in other patients. This again highlights the importance of identifying the high-risk patient. Here we've divided the patients according to whether they have 0, 1, 2, or 3 or 4 of the 4 high-risk features: polyvascular, kidney disease, heart failure, diabetes. And as the number of these high-risk features increases, there is a consistent relative risk reduction. In fact, it looks like it's getting bigger, but that's not statistically significant. The absolute benefits, however, go from 4 events prevented per 1,000 patients treated for 30 months to 53.9. And these are deaths. This is 53.9 deaths prevented for every 1,000 patients treated for 30 months. It's a 5.39% reduction in mortality. Very, very large benefits. You can use clinical characteristics to identify these patients. You can also count the number of risk factors, even just the number of cardiovascular medications at baseline, or you can apply a CHADS-2 score. I know that's for atrial fibrillation, but it's a score of vascular risk and works for chronic coronary or peripheral artery disease. I'm going to show you just one slide on the medication story, because this is where a lot of patients and their physicians get caught up. They say, "Doc, I'm already on a number of medications. I don't want to add another one." Well, on the left-hand panel, you will see that those who were taking 5 to 7 cardiovascular medications at baseline had the biggest absolute risk reduction. They had the highest risk and the biggest absolute risk reduction. So if you wanted to keep it simple, you just count the cardiovascular risk factors off, see how many CV drugs they're on. You can be confident, if they have the condition of interest, that if you add low-dose rivaroxaban, you're going to derive even greater benefits for such patients. What I've just said to you is entirely consistent with the latest version of the European Society of Cardiology recommendations. And you will see here at the top panel, adding a second antithrombotic drug, and there's reference to low-dose rivaroxaban, should be considered a 2A recommendation based on high quality evidence, that's A, and even those at moderate risk, it should be considered. Well, we can't treat everyone. And very briefly, who should we not treat? We shouldn't treat people with this dual pathway inhibition if they're already anticoagulated, say for a mechanical heart valve, if they have an unacceptable risk of bleeding or other contraindications. What's unacceptable for bleeding? It doesn't mean that someone who has a higher risk of bleeding shouldn't be treated, because as shown here, as the risk of stroke increases in atrial fibrillation, the risk of bleeding increases, but the risk of bleeding does not increase as rapidly as the stroke risk. And therefore, those at highest risk of stroke, and thus at highest risk of bleeding, actually derive the biggest benefits from anticoagulation. And the same applies to chronic coronary or peripheral artery disease. What's an unacceptable risk of bleeding? Well, some examples here: life-threatening bleeding, one event, or recurrent major bleeding. And the star indicates when the underlying cause cannot be identified or remains untreated. So if you have life-threatening bleeding, but you've dealt with the problem, you can start them on this therapy. But if you haven't been able to find the source or treat it, then you should avoid dual pathway inhibition. People with certain types of intracranial bleeding, people with severe thrombocytopenia, the dual pathway approach should not be used in such patients. What about contraindications? These are obvious. If you've got really bad kidneys with an eGFR less than 15, if you've got bad liver disease with an elevated INR at baseline, and certain drug-drug interactions. I come back finally to Mr. CVD. He's a 67-year-old man with previous MI, with previous angioplasty for peripheral artery disease. He is the absolute classic candidate for dual pathway inhibition. He has the condition of interest, cardiovascular disease. It involves 2 vascular beds. He has type 2 diabetes. He has chronic kidney disease. This man, I would suggest to you, absolutely must be treated with dual pathway inhibition. He also meets the guideline criteria. He has no contraindications. He does not have an unacceptable risk of bleeding. Chairpersons, ladies and gentlemen, let me summarize. I have presented to you a brief overview of dual pathway inhibition, one of the critical advances in antithrombotic therapy for long-term cardiovascular prevention. This therapy prevents serious events and it saves lives. People at highest risk get the biggest benefit. The challenge remains before you, as it does for all clinicians. We need to start employing this therapy in clinical practice to help further reduce the burden of cardiovascular disease in our patients. Thank you very much for your attention.
Thank you, Dr. John, for the very extensive and very educative session. And I have a query on that. Like with this talk, we know that the best people who need this dual pathway inhibition is patient with heart failure, ischemic heart disease, with mild renal disease, not on dialysis, without with the recurrent vascular events. But my question to the Dr. John is: suppose the last slide, Mr. MVD, that if the patient is having moderate risk of, bleeding and clotting, where you put, rivaroxaban versus ticagrelor of Pegasus trial in a patient with ischemic heart disease per se, not on heart failure or any other vascular event or kidney disease. Patient with stable heart disease with a moderate risk of bleeding and moderate risk of clotting, will you consider the ticagrelor arm in the Pegasus trial versus Compass of rivaroxaban? Dr. John, please.
He has some network issues. What do you think, Suresh sir? Can you just put a comment on what Dr. Ashraf has said?
Actually, we don't have a direct one-to-one comparison of aspirin and ticagrelor and aspirin and rivaroxaban for the treatment of coronary artery disease. As of now, the guideline clearly says that with the multiple risk factors, as he enumerated the multiple risk factors with the vascular disease, more than one vascular disease problems, there is definitely to consider for rivaroxaban. But there are no studies which compare and say that, use of aspirin and rivaroxaban in low risk or moderate risk patients are superior to the therapy.
I think the great whatever sir said is right, and to just enlighten the point, the greatest benefit is in the heart failure group, moderate, like mild to moderate, not severe, and cardiorenal syndrome, like patient already creatinine clearance of. So classically, diabetes, heart failure, ischemic heart disease with the EF of 35 to 40. So I think a very learning point to start the neuroanticoagulation.
I think so. We agree. If you are not going to hear from Dr. John, then can we conclude this session?
Yeah, sure. Because we are running late of 10 minutes. Thank you.
Thank you, sir. Thank you, Dr. Suresh Patel from Belgavi, and we had another chairperson, Dr. Ashraf from Kannur. Thank you for being part of this.
Thank you.
Thank you, sir.
Moving on to our next session by Dr. Rajesh T on the topic Adapting Post-PCI Current Concepts. We have our chairperson as Dr. Ashwal from Manipal and Dr. Srikanth from Udupi. Over to you, chairpersons.
Hello.
Audible?
Is my screen visible?
Yeah, screen is visible.
Okay, thank you very much. Can I start?
Yeah, please go ahead.
Please.
Thank you very much for this opportunity to be presenting here. I want to thank Dr. Manjunath, my senior in KMC Manipal, for this opportunity. It's actually intimidating to be speaking after an illustrious speaker like John Eckelboom, the setter of the COMPASS trial. But my topic is going to be very limited. It's about the DAPT in post-PCI, the current concepts of DAPT in post-PCI. Over the next half an hour, I'm going to discuss about the current guidelines of how this is evolved. If you look at the ESC and the American Heart Association guidelines published way back about 5 years ago, all of them, if you want to treat a patient post-PCI with ACS, and what is the current recommendation for antiplatelet agents, you have to risk stratify patients into two groups. One is a patient with a high bleeding risk and with a patient with a low bleeding risk. If you have a patient with a high bleeding risk, all the guidelines, at least post-PCI with a DES or a BMS, or universally state that you should be giving the antiplatelet agents for only 6 months. But if you have, and subsequently, you should tailor therapy based on the immediate events. Supposing you have a patient with a low bleeding risk and post-PCI, the guidelines, both the American College and the ESC state that you should be giving dual antiplatelets for at least a year. What about patients who are medically managed after an ACS? A minority of patients, I'm sure in your practice, will be managed medically because of various reasons, either they require only medical management or they're not suitable for revascularization. Again, the guidelines should risk stratify patients based on whether the patient has a high bleeding risk or a low bleeding risk. The patient has a high bleeding risk, and then the guidelines say, both the American College says that you should give antiplatelets only for 6 months, whereas the European Society says that you should stop antiplatelets, dual antiplatelets, after 1 month. And again, the patient has a low bleeding risk, you should, both the guidelines universally state they should give dual antiplatelets for 1 year. And based on the total ischemic burden, decide about whether the patient needs continued dual antiplatelet therapy. What about a stable coronary artery disease? Again, the 2016 guidelines, the American College says that you should give dual antiplatelets for patients with stable coronary artery disease who have a low bleeding risk at least for 6 months, and the patients who have high bleeding risk and who have stable coronary artery disease stop dual antiplatelets after 3 months. What about the European Society? Again, the European Society also says the same thing. 6 months of dual antiplatelets for patients post-angioplasty in stable coronary artery disease only for 6 months, and stop dual antiplatelets after 3 months in patients who have high bleeding risk. Now, how did this guidelines about 1 year post-ACS come about? If you look at this seminal trials like CURE, Triton, and Plateau trials, all these 3 trials have been the path breakers, as in the sense that they introduced the concept of long-term dual antiplatelet therapy, at least in the post-ACS setting. If you look at the CURE trial, which compared clopidogrel versus placebo therapy, they found that there was a significant benefit as far as major adverse cardiac events were concerned on the clopidogrel arm compared to the placebo arm. If you look at the Plateau trial, all of us know that ticagrelor scored over clopidogrel in reducing the risk of acute coronary events post-stenting or post-ACS. What about the Triton trial, which compared prasugrel and clopidogrel? Again, the Triton trial showed that prasugrel was superior to clopidogrel in reducing the risk of major adverse cardiac events. But if you look at bleeding in all these 3 trials, there was significant increase in the bleeding, at least in the minor bleeding and major bleeding was concerned in the clopidogrel, ticagrelor, and the Triton arms of these trials. I just want to focus on these 2 trials, the Plateau trial and the Pegasus trial, which has changed the way physicians treat patients post-ACS these days, particularly after stenting. I think when we started angioplasty way back 25 years ago, the only molecule available was ticlopidine and aspirin. After some time, we evolved changing ticlopidine to clopidogrel, and now over the last maybe 6 or 7 years, we've been treating patients post-ACS and post-angioplasty with a combination of ticagrelor, aspirin, or prasugrel and aspirin. And these 2 trials have established the role of ticagrelor, at least in the post-ACS setting. Again, I don't want to go in details of this trial. They showed that ticagrelor was superior to clopidogrel, at least in the 1 year data, which is in the Plateau trial, and the extended duration of ticagrelor at a low dose of 60 milligrams twice daily, plus aspirin, was the outcome on the Pegasus trial, which showed that 60 milligrams of ticagrelor and aspirin was superior to placebo plus aspirin in reducing the risk of acute coronary events, even as late as 3 years post angioplasty. Again, so this 2 trials have more or less established the role of dual antiplatelet therapy for at least 1 year and beyond 1 year as in the low dose of ticagrelor. Now, I just want to emphasize 2 important things, at least in this, as far as this topic is concerned, about the molecules we are using, the 3 molecules, the thienopyridines, mostly clopidogrel and prasugrel, and the CPTB inhibitors, that is ticagrelor. If you look at the thienopyridines, namely clopidogrel and prasugrel, they are irreversibly bound to platelets, and as a result, after some time, maybe after maybe a few hours after the therapy, you find some platelets actually not inhibited, because whatever, it's a complete inhibition of platelets, new platelets are generated after some time, and at one point of time, there will be some platelets which are not inhibited by this molecule. Compared to that, if you look at ticagrelor, this molecule irreversibly is bound to platelets. As a result, after some time, some of the platelets are, again, the newer platelets which are regenerated are again bound by this molecule, which is because irreversibly bound to the initial platelets. So this effect actually stays for 24 hours after inhibition, and this molecule is given twice daily. As a result, platelet inhibition is more or less complete with ticagrelor as compared to prasugrel or or clopidogrel. So this more or less shows the efficacy of ticagrelor vis-a-vis compared to prasugrel or clopidogrel. Again, if you look at this chart, which shows that both clopidogrel and prasugrel are prodrugs. They need to be metabolized into an active metabolite before they actually inhibit the platelets, whereas ticagrelor is a active metabolite by itself, and so the efficacy and the onset of action is considerably faster if you look at ticagrelor compared to prasugrel and clopidogrel. I'm aware that there's a new molecule called cangrelor, which is available IV, which produces more faster inhibition of platelets in acute setting. Now, if you want to discuss about the duration of dual antiplatelet therapy, you need to understand these terms. Short-term DAPT means 1 month or 3 months of dual antiplatelet therapy. Mid-term means 6 months, and 12 months of DAPT is nearly 1 year, and this extended term DAPT more than 12 months. Now, when you consider a patient for either short-term or long-term dual antiplatelet therapy, you need to consider these two important factors. The first is the ischemic burden. We call it total ischemic burden, and whereby we analyze the ischemic burden of each individual patient and then titrate therapy based on the duration of therapy is titrated based on the total ischemic burden of the patient. There are ways and means of analyzing the total ischemic burden, which I'll come to in the subsequent slides. The second thing, most important point you need to notice also is the bleeding risk of individual patient. So if the bleeding risk is considerably high, you need to tailor-made therapy to shorter duration of dual antiplatelet rather than extending it for a year or so. Again, the bleeding risk, the ischemic burden can be calculated by multiple ways. One is the patient-related factors, the coronary anatomy-related factors, and the stent-related factors. If you look at the patient-related factors, most of the patients who have diabetes, renal dysfunction, patients with congestive heart failure, patients with previous stent thrombosis, patients with peripheral arterial disease, all these patients are considered high-risk patients who would qualify for prolonged dual antiplatelet therapy. What about coronary anatomy-related factors? Long lesions, small vessels. We have done a complex bifurcation and standing a patient's complex anatomy, or a left main coronary artery disease, or a stent graft for the matter. You need to have prolonged dual antiplatelet therapy. What about stent-related factors? If you have put multiple stents, long stents, then again you should need to consider a dual antiplatelet therapy for a prolonged time. Now, you know to so this slide outlines the balancing act of the risk profile, the ischemic burden versus the risk of bleeding. If your bleeding risk outweighs the ischemic risk, like a patient who presents with the clinically significant bleeding on dual antiplatelet therapy, patient has advanced age, patient has female liver disease, peptic ulcer disease, patient has been using NSAIDs for a long time, patient has a bleeding diathesis, patient is already on anticoagulant therapy, or the patient has a high bleeding risk score, then the bleeding risk definitely outweighs the ischemic risk, and then you need to reduce the duration of dual antiplatelet therapy. On the other hand, if a ischemic risk outweighs the bleeding risk, like a patient who presents with recurrent stent thrombosis, a patient who presents with recurrent ACSs, patient's chronic kidney disease, peripheral vascular disease, prior ischemic stroke, LV dysfunction, and you're not sure whether the stent has been deployed optimally, you have calcified lesions and the stent is underexpanded, all these things, your ischemic risk definitely outweighs the bleeding risk, and you need to give a prolonged dual antiplatelet therapy. There are some situations where the patient has a short life expectancy and you would not want to continue dual antiplatelet therapy for a long time. Again, there are different risk scoring systems for quantifying the bleeding risk of a patient. This is the DAPT score. All of you know the score very well. The patient's age, diabetes mellitus, cigarette smoking, prior PCI, congestive heart failure, and the patient MI presentation, or vein graft PCI, or a stent diameter less than 3 millimeter. All these are given points. And if the patient has a high DAPT score of more than 2, it means that the patient has a high ischemic burden and a very low bleeding risk. On the other hand, if a patient has a low DAPT score of less than 2, it means that the patient has a very high bleeding risk and a low risk of low ischemic burden. Again, use the precise DAPT score to again risk stratify patients to quantify the risk of bleeding. Again, the score is based on the age, history of previous bleeding, the WBC cell count, hemoglobin, and creatinine clearance at baseline. So based on this, you have a precise DAPT score of more than 25. It indicates a high bleeding risk, and a precise DAPT score of less than 25 is considered a low bleeding risk. So combining a DAPT score and a precise DAPT score, you can risk stratify patients. You can quantify the ischemic burden, also quantify the bleeding risk of individual patient before you decide on prolonged antiplatelet therapy. This precise DAPT study, and along with a meta-analysis of around 15,000 patients from 8 randomized trials, they used this precise DAPT score, and they found out that a shorter duration of dual antiplatelet therapy was kind of beneficial in reducing the risk of bleeding and ischemic risk in patients who already have a high bleeding risk score of more than 25. If you look at all these trials which have evolved over the last maybe a decade or so, and most importantly, the Leaders Field trial, the Evolve Short DAPT trial, and the Global Leaders trial, all these looked at short duration dual antiplatelet therapy and the risk of ischemic events subsequent to the low duration of dual antiplatelet therapy. Again, the most important of these trials is Twilight trial, which I'm going to dwell in details. Again, looked at short duration dual antiplatelet therapy. If we look at the STOP DAPT trial 2, which looked at 1 month of aspirin and P2Y12 inhibitor, namely clopidogrel, and this was compared with the clopidogrel aspirin combination for 1 year versus clopidogrel alone after 1 month of dual antiplatelet therapy. And they found that this, the ischemic endpoints, namely cardiovascular death, MI, stent thrombosis, stroke, and TIMI major bleeding, was significantly less in the clopidogrel arm compared to the clopidogrel aspirin arm. Again, the bleeding events were considerably less in the short-term clopidogrel arm compared to the long-term clopidogrel arm. If you look at the conclusions from the STOP DAPT trial, 1 month DAPT followed by clopidogrel monotherapy provided net clinical benefit for ischemic and bleeding events over 1 year compared to dual antiplatelet therapy with aspirin and clopidogrel. So this was the beginning of the trials. We looked at short duration dual antiplatelet therapy. I want to emphasize on the important trial called the TICO trial, which looked at aspirin and ticagrelol. This is a Korean trial, 3 months of aspirin ticagrelol followed by discontinuation of aspirin and continuing ticagrelol monotherapy compared to long-term combination of aspirin and ticagrelol. Excuse me. And what did they find? They found that the 1 year clinical outcomes was significantly less in the ticagrelol monotherapy arm compared to the ticagrelol plus aspirin combination. Again, the 12-month clinical outcomes were again superior in the monotherapy arm compared to the dual antiplatelet therapy arm. So the conclusion from the TICO trial was ticagrelol monotherapy after 3 months of DAPT showed significantly lower risk of net adverse clinical events than a combination of ticagrelol and aspirin. And the bleeding risk also was considerably less. Coming to the Twilight trial, which is the most important of these trials, we showed that if we give ticagrelol and aspirin for 3 months after in high-risk patients, namely the patients who are high risk, that means they were above 65 years of age, they were females, they are troponin positive ACS, they established peripheral vascular disease, and they had diabetes with and chronic kidney disease, the eGFR of less than 60. These high-risk patients above 18 years of age who underwent PCI with more than 1 desk placement, they were triaged into a ticagrelol aspirin combination for 3 months, and then ticagrelol monotherapy and this ticagrelol aspirin combination for nearly 15 months, and this trial extended the observation period of 18 months. The primary composite endpoints of this trial was clinically relevant BARC bleeding type 2, 3, and 5, and the bleeding during the months of 3 to 15 months. The secondary endpoints were composite of all-cause death, non-fatal MI, stroke, and bleeding during the 3 months. So what are the Twilight primary endpoints? The BARC 2, 3, or 5 bleeding was significantly less in the ticagrelol monotherapy arm as late as 1 year after the beginning of this trial. And again, the composite of all-cause death, MI, and stroke, although it was not statistically significant, showed a trend towards the ticagrelor monotherapy arm as far as the benefit was concerned. Again, the composite of all-cause death, and MI, and stroke was slightly more or less equal in both arms of ticagrelor monotherapy versus ticagrelor dual antiplatelet therapy. The conclusion for the Twilight trial is in population of patients who are considered high risk for bleeding and ischemic events, who are tolerated ticagrelor DAPT therapy for 3 months. Ticagrelor monotherapy significantly reduced BARC type 3 of 2, 3, and 5 bleeding by 44% compared to ticagrelor aspirin combination therapy. So this is a very important trial which more or less established the role of long-term ticagrelor alone after stopping aspirin after 3 months. If you look at the meta-analysis of all the DAPT trials, which is published in Circulation in 2020, they concluded that extended term DAPT was ranked the best strategy for reducing MACE and definite or probable stent thrombosis, but least effective for limiting major bleeding. Short-term DAPT followed by aspirin and P2Y12 inhibitor monotherapy were ranked the best strategies for reducing major bleeding. And short-term DAPT followed by P2Y12 inhibitor monotherapy was ranked the best strategy for reducing net adverse clinical events and second best for reducing MI and MACE. Again, they also concluded that ticagrelor was the best strategy for reducing MI and major adverse cardiac events as far as the dual antiplatelet therapy, monotherapy was concerned. Again, the global leaders trial and the GLASSY sub-study also showed that dual antiplatelet therapy with aspirin and ticagrelor for 1 month followed by ticagrelor alone was superior to a combination therapy in reducing the major adverse cardiac events. We just heard about dual pathway inhibition by John Eckelboom, who confirmed that a small dose of rivaroxaban and aspirin could be a best way of preventing adverse events in the long term, maybe 2 or 3 years after a PCI. Now, I just want to conclude by saying that you need to use routine risk scoring, preferably precise DAPT score and DAP score in a clinical practice when you are accessing the ischemic burden and risk stratifying patients based on the bleeding risk. A high bleeding risk patient with a low total ischemic burden patient should be treated, and particularly who has had a newer generation death with short duration DAPT or 1 month, followed by preferably a ticagrelor monotherapy to avoid bleeding events and retain the benefit of antiplatelet therapy. A patient who has a low high bleeding risk and a high total ischemic burden should be given extended duration DAPT for at least 1 year or longer duration DAPT. I want to thank each one of you for the patient hearing. I will be open for questions at the end of this talk. Thank you very much.
Thank you, Dr. Rajesh, for your excellent talk.
Thank you.
I have just one question. Can you please elaborate your approach to patients who require concurrent use of anticoagulations? Can you elaborate for this for the benefit of budding cardiologists who are attending this program?
Yeah, I think we have evidence from Aristotle trial that if you want to give oral anticoagulants along with dual antiplatelets, I think you need to tailor-made your therapy based on the bleeding risk. If a patient has a high bleeding risk, you should consider a short-term dual antiplatelet therapy and continuing a single antiplatelet therapy or a combination of clopidogrel and apixaban beyond 3 months of therapy in patients who have received a recent stenting. And a patient who has a low bleeding risk therapy, you need to continue dual antiplatelets for 3 months and later on give a single antiplatelet and apixaban for the rest of the period. So just want to emphasize the quantifying the bleeding risk in individual patient before you tailor-made your therapy.
Thank you very much, sir. Is there any questions in the chat box?
I would like to ask Dr. Rajesh one more question. Is there any role for de-escalation of the antiplatelets? That is to say, first 3 months use aspirin plus ticagrelor and subsequently switch over to aspirin and clopidogrel. Is there any role for this?
Yeah, I think there's a role, particularly in patients who have an increased ischemic burden. Normally, the practice has been to give dual antiplatelet therapy for 3 months, and based on the ischemic burden, continue further antiplatelet therapy. Normally, the practice in our center has been to give dual antiplatelets for 3 months, and subsequently, if the patient has a low ischemic burden, give them only ticagrelor for a year or so. There are a group of patients who also have significant ischemic burden and who have a recent history of upper GI bleed, would not be a candidate for aspirin therapy along with ticagrelor. In those patients, I would consider a combination of ticagrelor and clopidogrel in these patients who have a significant high ischemic burden, but also a history of previous bleeding, which was probably related to aspirin.
Thank you.
Thank you very much, Dr. Rajesh. Dr. Shrikant, is there any more questions you would like to ask?
Just one question. This is regarding a patient I have been treating. Patient had multiple recurrent acute MIs, and we later realized that he had hyperhomocystinemia. He had acute MIs on clopidogrel as well as ticagrelor. And till we lowered his homocysteine levels, he had recurrent MIs. Now it is 1 year and he has 3 stents in the LAD. Now, how do I go about DAPT? Do I go for 60 mg ticagrelor, or do I go for aspirin with rivaroxaban?
I would probably, if I would answer the question, I would probably give him aspirin and rivaroxaban,
okay,
compared to ticagrelor monotherapy. I don't know what other chairpersons also, what do they feel about this? I want to hear from them also.
Rivaroxaban is a better drug, sir, because patient has always homocystinemia and patient has high risk of thrombotic episodes elsewhere also. So it would give a better benefit. Yes, sir.
Thank you very much. That's what is the plan. Thank you very much.
Thank you very much. Thank you, Rajesh, sir. Once again, I thank you very much. And I think we can conclude this session. Thank you.
Thank you, Dr. Raghu. Thank you, chairpersons. Moving on to our next session on the topic translational paradigms in coronary imaging with HD, IV US by Dr. Tanuj Bhatia from Dehradun. To chair this session, we have with us Dr. M.N. Bhatt from Mangalore and Dr. Mansoor from Kasaragod. Over to you, chairpersons.
Good evening. Good afternoon, everyone. As you all know, IVUS is an important supplementary tool during a PCI, particularly if it is a left main PCI or a complex PCI. And to add to that, we have newer innovations in IVUS, that is the HD IVUS. To talk about this further, we have among us eminent speaker, Dr. Tanuj Bhatia. Over to you, doctor.
Good afternoon, everyone. First of all, I would like to thank the organizing committee, Manjunath sir, for giving me the opportunity to be speaking in front of such an esteemed audience, all these stalwarts of cardiology. So I would be discussing the translational paradigms in coronary imaging, especially with the advent of HD IVUS. So as we all know, the gold standard is a 2D planar silhouette of the artery with the angiogram. But we know the limitations of an angiogram, that it might inaccurately measure the true extent of local stenosis, especially if the artery is positively remodeled, hence masking early atherosclerosis, and it has no indication of the vessel wall characteristics or the plaque burden. Then came the imaging by the sound waves that were transmitted and received by a transducer that were mapped into a grayscale and gave us a cross-sectional image of the artery. The luminogram went we went inside the artery. We saw that over the period of time, we have realized that the artery segments that were apparently normal, it was only less than 10% of the time that they were actually disease-free. Hence, the importance of imaging, especially in subsets where there is some contradiction between our imaging findings. There is some ambiguity between the clinical picture and the angiogram, especially in calcified lesions, detecting a vulnerable plaque, and especially finding the cause of a stent failure. And there is an immense benefit of imaging, especially in bifurcation stenting. So we have a lot of data supporting the use of IVUS, especially the ADAPT-DES trial, the IVUS XPL trial. There is a meta-analysis of all these trials and various smaller studies. First of all, let's discuss about the ADAPT-DES trial. It is the largest trial that supports. It had a pre-specified IVUS sub-study that compared IVUS versus plain angiographic guidance, and it was seen that approximately 74% of the time, the use of IVUS changed the procedure. Sometimes with the use of a larger size of a stent and balloon that was expected angiographically, sometimes using more aggressive post-dilatation for an under-expanded or a malapose stent, or using higher pressures of NC balloon dilatation, and sometimes even adding an additional stent for a disease that was being missed angiographically. And at the 2-year follow-up, it was seen that the MACE was significantly lesser in the IVUS subgroup as compared to the patients those who were managed by plain angiographic guidance. And the next study in this accord randomized some odd 700 patients to each arm of IVUS versus angiography, especially patients those who had implanted long coronary lesions of a stent more than 28 millimeters of length. And it was seen again that the MACE was significantly lesser in the IVUS guided subgroup as compared to angiographic guided subgroup. However, it was mainly driven by target lesion revascularization. And similarly, the data from the ultimate study also points a similar reduction in MACE of 2.9% in IVUS guided subgroup as compared to 5.4% in angiography guided subgroup. All these summed together in meta-analysis do favor, and it has been seen that IVUS guidance has been associated with the use of larger stents, more number of stents, longer stents, and a larger post-procedural MLD as compared to angiographic guidance subgroup. And there has been a significant lower rates of MACE, death, MI, stent thrombosis, all individually, and even target lesion revascularization over follow-up. So despite such strong data, we do understand that the penetration in clinical cardiology practice is still low. One of the reasons is the time and cost that we presume that it might take, especially with IVUS, more with IVUS, less with OCT. There has been a delay in learning curve. And for those who are experienced enough, they sometimes feel that since they have already mastered the technique, they no longer need it. And especially, as I said earlier, the learning curve with IVUS is slightly difficult as compared to OCT. That leads to underuse in the clinical practice. So one of its competitors with OCT leads to a slightly reduction in the use of IVUS in clinical practice. And if we talk about cost effectiveness, a study has shown that IVUS guided practice over the long term is more cost effective as compared to angiographic guided PCI. And despite this fact, as of now, there is just a class 2A recommendation for use of IVUS or imaging in angiographically indeterminate left main lesions and in-stent restenosis. However, it is a class 2B recommendation to use in indeterminate non-left main lesions and for stent thrombosis. These guidelines have been slightly upgraded in the recent past. I'll exemplify it I'll start with a very, very simple example. It was a multi-vessel PTCA patient who had a revascularization in 2016 and presented approximately 3 years later with an unstable angina. However, it was troponin positive, so better to call it as non-ST elevation MI. And the angiography documented just an intermediate disease in the mid-LAD, just distal to the stent. To be sure whether the lesion is actually significant, we took a IVUS run that showed that the distal edge of the LAD stent had a under expansion, and just distal to that, there was a HISR with a significant fibrofatty plaque. And at that point, FFR was done to confirm our strategy. The FFR came out to be 0.76, and the patient after revascularization achieved a FFR of 0.92. So just to see the figures, we understand that despite the presence of intermediate stenosis, a value of MLA might not help us guide the strategy, but delineating the plaque, especially like in this case, there was a difficulty in correlating with the intermediate stenosis. The MLA helped us, and the plaque burden at the distal edge helped us commit to the strategy. So we do have a wide variety of non-invasive and invasive methods. And in summary, we use practically just these three: angiography, OCT, and IVUS. And if we talk about the depth, the best depth evaluation is by IVUS, although the spatial resolution is modest with the use of IVUS. However, with a great spatial resolution of OCT, but a poor depth of OCT leads to use of IVUS, especially in larger vessel structures like left main and ectatic or larger luminal diameter vessels. However, with the advent of HD IVUS, the spatial resolution of IVUS has improved and might be comparable to OCT in especially certain subsets. Additionally, we do have certain disadvantages of OCT, like additional contrast, limited penetration of OCT. Predilatation might be necessary to help allow blood to be flushed from the lumen in all OCT runs. On the contrast, we have extensive clinical experience with IVUS. Pre-intervention imaging is possible in most of the patients without predilatation, and IVUS predictors of restenosis has been well established over the periods of years. But again, the disadvantages that we do have limited tissue characterization. We have difficulty in assessing the thrombus. It might be challenging, but with the advent of HD IVUS, there might be some improvement in detection of these characteristics as well as our ability to interpret these images. So this higher definition, the 60 megahertz of HD IVUS may have a superfine axial resolution as low as 40 microns. And the high depth of penetration help us additionally assess the full plaque burden as well as especially in left main cases. And another advantage of these HD IVUS catheters is that they have a novel offset tip design, and it has a distal tip to transducer distance of only 20 millimeters that help us access have it move on a monorail very easily. And the crossing profile at the distal tip is just 2 French as compared to OCT, and it's more deliverable in certain subsets. And it, as discussed, it is easy to repeat our interpretation, repeat our imaging without the use of contrast with every injection. So if we compare head to head the Volcano, the Boston, the Abbott, and the ACIST, we do understand that the axial resolution has been improving over the period of time, and it might be very good with OCT catheters, approximately 15 micrometers, but it is almost comparable with a high definition IVUS catheter that is approximately 40 microns. So just for a comparison, the conventional IVUS as well as a 60 megahertz high definition IVUS, we can see the better delineation of the intima media as well as the internal and external elastic laminae in this image. It is just more important that we try to understand and interpret these images, identify the lumen very clearly, identify the plaque localized in the intima and media very clearly, and see the adventatia for the cross-sectional image. And we can have certain additional value with the longitudinal image as shown in this figure. A typical IVUS summary assesses in the pre-intervention stage by assessing the plaque composition, area stenosis, plaque burden, MLA, and during intervention helps us size our interventional device, and even post-intervention helps see the stent expansion, apposition, and identify stent edge dissections. And as discussed, the HD IVUS has a lot of similarities with OCT. It is trying to overcome the limitations of the conventional IVUS. And over the period of time, we are understanding more about the interpretation of these images and how we can apply in all clinical settings. These are certain basics that we should identify the plaque composition. A soft plaque, fatty plaque might not appear as bright as adventitia. It is hypoechoic, probably due to the high lipid content in a mostly cellular lesion. However, reduced echogenicity may also be due to necrotic zone within the plaque, IMH, or thrombus. We should also have a clear eye on the fibrous plaque. However, a fibrous plaque, though conventionally has an intermediate echogenicity between a soft and a calcified plaque, it may produce an echo shadow by attenuation of a echo signal, mostly because they might be associated with deeper lipid cores, and these echolucent cores may help us impact our selection of landing zones, because they might lead to more slow flow if we, as compared to pure fibrotic plaque. So we should try to identify, usually the echo shadowing is usually seen in calcified lesions, but in absence of calcified lesions, if we see a deep attenuated plaque, it might point to a deeper lipid core as well. So another subset where the importance of imaging is that is a calcified plaque, also called as echo dense or echo reflective plaques, that are much brighter even than the surrounding adventitia, and because of its highly reflective nature, it produces a acoustic shadow. And IVUS has the only limitation with IVUS as compared to OCT is that it might not help us detect the thickness of the calcium deposit. Besides that, we should try to classify our plaques into concentric and eccentric plaques that help us take our decisions. So the detection of calcium impacts our pre-procedural planning. And one of the examples, I'll exemplify with the example. It was a 69-year-old male with a post-PTCA status to LCX in 2011, and a PTCA to LAD was attempted in 2016, presented to us with unstable angina, and the patient already had a LAD CTO, but it was attempted earlier, and the patient presented with repeated angina episodes. And this was a LAD chronic total occlusion, a relatively long occlusion bend within the calcified occlusion, and we were not able to cross any interventional device except for a feeder wire. Even a micro catheter would not go and would just push the guide back because of possibly the lesion angulation. And the shortest balloon on shelf that day was 1x6 NC balloon that also had accidental granuloplasty while trying to attempt the crossing of the lesion. So subsequently, once we did the rotablation, we could see a very, very, very heavy calcified plaque, probably having sheets of calcium, more than 270 degrees of arc of calcium. And it was only after rotablation and high pressure NC balloon dilatation that we could achieve the break of the concentric calcium. It was pre-dilated with the 3x10 NC balloon followed by a DES, and we had an acceptable final result angiographically as well as by IVUS. So what are the criteria that help us plan our interventional device? In IVUS specifically, the criteria are a circumferential calcium more than 5 millimeters of length, more than 270 degrees, that is 3 quadrants of calcium, a calcified nodule, or a vessel size less than 3.5 millimeter. As we can see, the criteria for heavy calcification in IVUS are starkly different from the criteria in OCT, where the thickness also plays an important role in sizing or in planning the interventional device strategy. However, like in this case, it was a balloon uncrossable lesion. The strategy is rotablation even without imaging, as it is not possible in such a case. And it has been seen that even in CTOs, like in this case and in other CTOs as well, IVUS guided strategy improves the late lumen loss as compared to angiographic guided PCI. Another importance is the presence of calcium, whether it is on the myocardial aspect or on the pericardial aspect, whether there is a wire bias in the calcified plaque. I'll exemplify again with the example. It was a 60-year-old, very low body weight postmenopausal female presented to us with acute anterior wall MI, and there was eccentric calcium, there was a wire bias, and we did not use rota for the fear that we might have a coronary perforation. We gradually pre-dilated and the lesion did give way with the NC balloon, and we had a reasonably good result with a pre-dilatation. But due to the under-expanded stent in the distal part, we thought of just doing a soft post-dilatation at that site. But during the post-dilatation, the lesion gave way towards the pericardial aspect, possibly because, the patient landed up in a perforation. The next 4 minutes were full of adrenaline rush, but since we were slightly prepared, seeing the eccentric calcium, the covered stent was on board and a covered stent was deployed, and we had the sealing of the perforation immediately. This just exemplifies a very important fact, that the localization of calcium relative to the epicardium should be seen at a cross-sectional level, because if there is eccentric calcium, it might lead to perforation towards the pericardial aspect, especially if that eccentric calcium, that calcium burden is more towards the myocardial aspect. The next limitation that we know of HD-IVUS as compared to OCT is the difficulty in assessing a plaque rupture or a plaque erosion. Plaque erosion is in fact defined on the basis of OCT findings only. But what do we have? And even in the discussions recently, there has been a paper that says in all ambiguous angio, intracoronary imaging should be done to identify the plaque event. But again, the difficulty to identify a plaque rupture or erosion on OCT is easier. The classification or the delineation of early fibroatheroma. But if we see comparable images of HD-IVUS as compared to OCT, we can see that with a slightly lesser beauty of the picture, if we are able to identify the lipid pool, the necrotic core, the fibrotic element, we might see comparable images, the MLA similar, the assessment of the fibrotic cap is similar, and it is similar even for cases with thin cap fibroatheroma, especially in cases, and it is easier to see the superficial calcium in IVUS, HD-IVUS. The only limitation is again not being able to assess the thickness of calcium in calcified lesions. So in an acute ACS condition, especially with the indeterminate angiogram, the importance of imaging is cannot be more emphasized. This example in which a patient presented to us with non-ST elevation MI, no localizing signs on ECG, just a mild disease in RCA. This was the angiographic appearance of the left anterior descending artery that can be best called as a moderate disease, but IVUS evaluation led to a beautiful see us a beautiful picture. And if you can see the HD-IVUS images from proximal LAD to distal LAD, you will identify a eccentric plaque in the mid LAD with plaque rupture seen on the HD-IVUS, and there is intraplaque hemorrhage as well. You could see the blood flow within various cavities into the plaque, as pointed out by the red outline in these images. This was a blood-filled cavity within the plaque, and you can see the plaque rupture. Similar images of such might be much beautifully identified on OCT, but with HD-IVUS, we can see that we can identify such lesions, such discontinuity of the fibrous cap overlying a lipid-rich core. And a similar image of which may be called as a lotus stem appearance of a recanalized thrombus might be seen with OCT, but a similar image of plaque rupture or a recanalized thrombus can be seen in such cases. Another problem is the blood speckling that might interfere with that interpretation. But just like OCT, we might have a high-speed fullback with flushing of IVUS, HD IVUS, to delineate such intimal or plaque events. The next category of patients in which HD IVUS plays a special role is bifurcation stenting. The first example I'll take with a left main bifurcation PCI. It is a distal LM Medina 111 angiographically appearing critical stenosis of ostial LAD as well as ostial left circumflex artery patient, and we took a dedicated two-stent strategy in this patient. Pre-dilatation was done towards both these vessels especially, and we could notice a significant dissection in the proximal LAD, and thereafter the IVUS pullbacks were taken. The importance of IVUS in such cases is to see whether we need to use any other adjunctive equipment in such a case. The lesion in LAD was predominantly a mixed fibrofatty calcific plaque. We can clearly identify the distal landing zone, identify our equipment, that the stent size that we'll use according to the distal landing zone, identify the total lesion length in such a case, identify the exact plaque burden at different sites, the plaque nature, it's fibrofatty. More proximally, we can see various planes of intimomedial dissection, although we have an eye of seeing dissections on OCT very beautifully, but just for comparison with OCT, this image also shows the dissection very beautifully extending deep into the media as well. And as we know, large dissections, if they are detected by IVUS or OCT, they are independent predictors of MACE, and any dissection that is extensively lateral, more than 60 degrees of in the circumference, extending more than 2 millimeters, involving deeper layers, and a presence of residual plaque burden should be handled. And if we see the IVUS images at the right at the ostial LAD, we can see a significant calcium burden to encompassing the arc of approximately 180 degrees with a MLA in distal left main of 4.5 millimeters square. So again, the importance of MLA, especially in left main as compared to the proximal area, is important. And now we in fact have a recommendation, or maybe I'll say a practice guideline, that if we have a MLA of more than 6, we might leave the patient conservative. If the MLA is less than 4.5, we might upfront choose a revascularization strategy. And if the MLA is between 4.5 to 6, we might consider physiological assessment. However, we should individualize our strategy. And for this case, we don't need this recommendation. It was just for discussion sake that I mentioned here. And the assessment in the ostial LCX showed a superficially attenuated plaque. And again, it was handled with the T stenting strategy, and followed by a final pot and a final kissing balloon inflation. So post procedurally, what is important is seeing the apposition, seeing the carina, identifying the MLAs at various sites. And additionally, like in this case, we could see that the LAD, left main to LAD stent was landing at a site of fibrotic plaque. It was slightly underexpanded in the distal site that was again dilated with a high pressure post dilatation, and this is the site of the distal LAD stent, and we've landed the stent in a fibrotic zone comfortably. We left it unintervened because the plaque burden was just 37%. It was purely a fibrotic plaque, and even a FFR value was 0.94. So the final pot and kissing was done, and these are the angiographic images, and the final IVUS documented a good MSA at all sites, proximal LAD, LCX, polygon of confluence, and left main. Especially if we are using dedicated two-stent strategies, like in this second patient, we can see a Medina 111 distal LM bifurcation disease, and we can see a very, very ectatic coronary in left main coronary in the angiogram itself. And although the patient was advised CABG, especially in dominant LCS, but due to borderline hemodynamics, he was taken up for PCI. And the imaging helps us strategize our approach in various ways. After NC balloon dilatation and pre-dilatation of both osteal LAD and LCX, the strategy was chosen to be DK crush, especially in this case. And the imaging also showed that we needed to aggressively dilate the osteal LAD site because it had a heavy calcification that needed to be managed with a high pressure NC balloon dilatation. And until and unless we documented the stent fractures in various sites, we were not comfortable going ahead with left main to LAD stenting. And this was finally completed with a DK crush strategy. And the final IVUS imaging showed a good result and good expansion at all the sites like in the previous case. So, and even post procedurally, a concentric proper expansion of the stent should be documented, and eccentric expansion of the stent should be handled accordingly. This is the discussion about the bifurcation stenting. Now, an important subset is the stent failures. The patients, those who present to us with stent failures, I'll exemplify this with the example. This was a patient with ischemic cardiomyopathy that presented with recurrent stent failures. He underwent 2 or 3 procedures in the past, but had very extensive and aggressive atherosclerosis. And this time when he presented in November 2020, he had pressure damping on hooking the left main. And as we can see a stent failure in the distal LAD stent as well. And a quick assessment of the left main was done. And the intention was to treat the left main bifurcation, but just for the sake of discussion, for the stent failure in the distal LAD, we can see that the distal LAD stent is slightly underexpanded as compared to more proximally where the MSA is 4.2. Distally, the MSA is much less, 2.7. And more proximally in mid LAD site, if you can see carefully in this image, it is not a homogeneous appearance in the plaque inside the stent. It is basically a heteroechoic appearance, and the starred area is the lipid core. The echolucent area is the lipid core, suggesting neoatherosclerosis in such a case. So we definitely, neoatherosclerosis is best identified with the OCT, but with the advent of HD IVUS, neoatherosclerosis might be feasibly identified with the HD IVUS in various situations. And this was handled accordingly. Neoatherosclerosis should be treated with a stent rather than just post-dilatation or a drug-eluting balloon. And more proximally, we could see calcium sheets, and the left main also, as discussed earlier, had a MLA of 4.8 millimeters square. Just right at the ostial left main, the MLA was just 4.2 millimeters square. And this patient was eventually treated with a left main bifurcation PCI and additional DES in the distal LAD at the site of neoatherosclerosis, and just with a post-dilatation at all sites of underexpanded stent. And a final result was again documented with good MSAs achieved at all levels of LM, polygon of confluence, LAD, and LCX. And this is again a RCA CTO ISR presented to us with class 2 angina, long-standing. The PTCA to RCA ISR was contemplated. The lesion, it was completed with a stent only at the proximal and distal site, because the IVUS imaging showed that there was a edge ISR both at the proximal and distal edge, and rest of the stent, the entire RCA, was just a underexpanded stent. We did not have to use anything else except for high pressure post dilatation in the entire length of stent. And this is the final angiographic result that you can see. So we could avoid, it's not that IVUS leads to a higher number of stents, sometimes it actually leads to a lesser number of stents, and it has to be taken with a pinch of salt. And especially in left main cases, this is the last thing that I would like to highlight. There have been doubts about the LCX ostia, especially recurrent stent failures in left main bifurcation PCI or ostial LCX lesion. There have been doubts around the LCX ostia, and it has been noted that irrespective whatever the Medina classification is, if there is a plaque in distal LMCA, it continues as a plaque in LAD and LCX in 62% of the cases. So the angiogram hides the truth in most of these cases. Like in this case, I'll exemplify the case a bit later. Just the importance of LCX ostia is that even when we are planning a left main to LAD crossover stent, there is a very, very importance of identifying about the identifying the nature of plaque burden right at the LCX ostia. And if the pre-procedural MLA of LCX ostia is more than 3.7 millimeters square and the plaque burden is less than 56%, it virtually excludes the possibility of functional LCX compromise. However, if the values are converse, even then there is only a 15% chance that we'll have a crossover. After a crossover stenting, we'll have a significant plaque shift towards the LCX ostia. And in most of these cases, we should try to identify the functional significance of the LCX ostia rather than going by the imaging finding itself. So this was a recurrent case of LCX ostial ISR. The patient presented to us with unstable angina. He had underwent multiple procedures earlier. He has extensive diffuse atherosclerotic disease, but the FFR2 RCA also had a lesion, the apparently severe, but the FFR2 RCA was 0.96, FFR2 LAD was 0.92, and FFR2 ostial LCX was 0.72. And the imaging documented a double strut right at the LCX ostia that were purely underexpanded. The patient again just needed just a high pressure post dilatation, and this was done with the OPN-NC balloon, and thereafter the angiographic result was fine, and the patient at 6-month follow-up is doing well. So these are basic subsets where IVUS imaging helps more than the angiogram, and the use of IVUS should be done in the pre-intervention setting to identify the lesion morphology, lesion significance, documenting apposition, geographical miss, and dissections during procedure and post-intervention, and during seeing for any complications. So to summarize, yeah.
So with the interest of time, we kindly request you to conclude as soon as possible.
So this is the summary slide. So HD IVUS has comparable resolution, but a better depth as compared to OCT, and may help us identify histopathologic stages of atherosclerosis. And in most of the cases, especially in left main bifurcation or ostial lesion, it is a very, very good alternative, and especially when we need repeat assessments or multi-vessel imaging. Thank you very much.
Thank you, Dr. Tanuj. It was an excellent demonstration of the use of IVUS, particularly in complicated PCI as well as in left main disease. In particular, IVUS, especially HD IVUS, is showing superiority definitely over the OCT for left main interventions and bifurcation interventions. And as such, many of the patients may be having associated CKD or borderline chronic kidney disease, where we may not be able to give more contrast in with the OCT, in which case IVUS will definitely require less contrast usage. And so in such cases also, I feel the IVUS will be of a benefit, and you have also demonstrated how to use it and how nicely you can get a better results with this. In addition to that, trials are also promoting it, and it has got a class 2A recommendations summarizing. So if there is any other questions, we can take it now. Any questions in the box, or anyone has any other questions?
No, sir. Can we proceed with the next talk, please?
Okay, thank you. Thank you, Dr. Tanuj.
Thank you very much, sir. Thank you for the opportunity.
Thank you, Dr. Tanuj. Thank you, chairpersons. We'll be moving on with the next talk by Dr. Girish B. Navasundi on the topic management of AF patients with ACS undergoing PCI. We have our chairpersons, Dr. Syed and Dr. Gaurav Thakre. Over to you, chairpersons.
Good afternoon to everyone, and Dr. Girish. It's a challenging topic that we are management of the atrial fibrillation in association with the ACS. We have a developed disorder whether we should anticipate ischemia or the hemorrhage by using the anticoagulant along with the dual antiplatelets. Here we have a Girish. You can give more information. Over to you, sir.
Thank you. Thank you, chairpersons and the organizers, to have constructed this beautiful program on the Sunday morning. I have been asked to speak on the, very contentious, but which is getting more and more clear, how to manage this complex clinical syndrome of atrial fibrillation presenting in the background of a severe coronary artery disease, either ACS undergoing a PCI. As we all know, the patient with non-valvular atrial fibrillation with recent acute coronary syndrome and or who have undergone a PCI is a challenging subset when it comes to antithrombotic therapy. You need antiplatelets 1 or 2 with at least 1 anticoagulation. Require anticoagulation for stroke risk reduction associated with non-valvular AF, and they require add-on single or dual antiplatelet therapy for reducing the risk of ischemic events in ACS, such as myocardial infarction, death, or stent thrombosis. Combining these regimens increase the risk of bleeding. The optimal combination of anticoagulation and antiplatelet therapy, which balances both bleeding risk and thrombotic risk, is unknown at this point, but clarity is emerging. Coronary stenting in patients with atrial fibrillation at high risk of stroke, we cannot simultaneously prevent all 3 problems, that is, stent thrombosis and stroke and major bleeding. If you try to reduce stent thrombosis and ischemic stroke, there'll be increased bleeding. If you try to reduce increased bleeding, then you increase the chance of stent thrombosis or a stroke. So you need to strike this balance, and that depends on the patient's profile and the class of medication and the duration of medications and the dose as well. Comparison of the 3 trials which existed so far, when you look at the Pioneer, Redual, and Augustus. In the Pioneer study, where they used rivaroxaban, here there was about 2,100 patients. The day of aspirin prior to randomization, as the chief culprit for bleeding, less than 3 days, and also great benefit in terms of acute thrombosis reduction for stent. The type of therapy here was triple versus double in Pioneer. And then you had a dosage of rivaroxaban being 15 milligrams once daily constant. And majority of the patients, more than 90 patients, received P2Y12 inhibitor in the form of clopidogrel, and ticagrelor was seen only in 5% of the patients. And all of these patients underwent PCI. So Pioneer was basically a PCI in an AF and CAD. None of the patients had prior stroke. In the Redual, you had 2,500 patients, and the use of aspirin prior to randomization was less than 5 days. Here you compared the triple therapy versus double therapy. That is ticagrelor with clopidogrel versus vitamin K antagonist, aspirin, and clopidogrel. Here there were 2 strengths of ticagrelor was used, 110 milligram twice daily or 150 milligram twice daily. Ticagrelor usage was 10%. I'm sorry, in this, not ticagrelor, the PCI for all stable or ACS patients were used, and the prior stroke was not seen any of the Redual patients, where they used a dabigatran, not ticagrelor, I'm sorry. The dabigatran was used in the dose of 110 milligram twice daily or 150 milligram twice daily, but only 10% had ticagrelor use and about close to 90% had clopidogrel. In the Augustus, what we would be discussing has almost double the number of patients, about 4,600. And here the days on aspirin prior to randomization was about 6 days as a mean, 0 to 15 days. What did we compare here was a triple dose, a triple therapy versus triple therapy. That is aspirin, clopidogrel, apixaban versus aspirin, clopidogrel, and vitamin K antagonist. And also there was a double head-on-head comparison between, here the aspirin was deleted. You looked at apixaban and clopidogrel, vitamin K and clopidogrel. The dosage here was 5 milligram twice daily of apixaban. Ticagrelor was used only in 6.2% of the patients, and study patients had atrial fibrillation plus ACS or they had undergone a PCI. It's a mix of both who were managed medically or conservatively without PCI, with PCI. Coming to the Pioneer study, patient with atrial fibrillation undergoing coronary stent placement who had a PCI, Pioneer AF PCI study. Here there were 2,100 patients and coronary stenting was done, and none of them had prior stroke, TIA, GI bleeding, or a hemoglobin less than 10 or a creatinine clearance less than 30. In less than 72 hours, they were randomized after sheath removal. After sheath removal, they were given either only dual therapy, that is rivaroxaban 15 milligram once daily and clopidogrel 75 milligrams once daily from the beginning till next 12 months. This like voice-like study dosage. Rivaroxaban 15 milligram OD, clopidogrel 75 milligram OD throughout the study period of 12 months. And then you had second randomization where we used rivaroxaban 2.5 milligram twice daily, clopidogrel 75 milligram once daily, and aspirin 75 to 100 milligram once daily. This was a triple therapy, and the duration of triple therapy was between 1 month, 6 months, or 12 months, left to the choice of the MD who randomized the patient. Usually beyond 1 month, 6 months, or 12 months, the patient went back to rivaroxaban 15 milligram once daily and aspirin 75 milligrams once daily. And I think beyond 12 months, it was only anticoagulation, no antiplatelet. The third group, again, between 1 to 6 months or 12 months, patients were given triple therapy of aspirin, clopidogrel, and VKAs with an INR between 2 to 3. And beyond that 1 or 6 months, patient was put only on aspirin and VKA, not clopidogrel and VKA. Pioneer AF PCI summary of the results, when you look at it, the rivaroxaban plus P2Y12 inhibitor fared far superior to vitamin K antagonist warfarin and dual antiplatelet. That is a triple therapy. Compared to triple therapy, dual therapy of rivaroxaban 15 milligram plus clopidogrel was superior in terms of reducing significant bleeding, major bleeding, minor bleeding, bleeding requiring medical attention, but MACE was almost same. Stent thrombosis was slightly higher. When you look at the rivaroxaban 2.5 milligram BD plus DAPT, the additional benefit here, that is triple therapy involving rivaroxaban 2.5 milligram along with dual antiplatelet versus DAPT plus warfarin, the MACE was slightly better when you added rivaroxaban 2.5 milligram, but stent thrombosis remained still high. This Pioneer provided initial important evidence in the field where it had been lacking. It was a groundbreaking trial. There's a clear signal of less bleeding with both reduced antithrombotic regimens, whether you use no aspirin or very low dose of oral anticoagulation such as rivaroxaban 2.5 milligram along with dual antiplatelet therapy. They said there is a great benefit. It needed to be studied further. But this study was not powered for efficacy, and effects on ischemic events were imprecise with wide confidence intervals for stroke varying between 0.39 to 2.9, for an aspirin between 0.5 to 3.58, stent thrombosis, again, when there's no aspirin, 0.32 to 4.5. So it was very imprecise for efficacy. And then came the next anticoagulation antiplatelet cocktail study, that is Redual PCI. Here the trial design was, the primary endpoints were time to first ISTH major bleeding or clinically relevant non-major bleeding event. About 2,500 patients. In 3 arms, there were about 834 patients each. Here the patients had either paroxysmal or persistent or a permanent non-valvular AF, and PCI with stenting was done either with BMS or DES, elective or for ACS. It was not only for ACS, whether elective or ACS. Patients were screened, randomized 0 to 124 hours post PCI, 0 to 120 hours. And patients more than 8 years living abroad were given 110 milligrams rather than 150 milligrams of dabigatran. The redual PCI had 3 arms: dabigatran 150 milligram BID plus P2Y12 inhibitor. That's a dual therapy, clopidogrel and dabigatran 150 BID. The second arm was dabigatran 110 milligram BID plus clopidogrel alone. And the third arm had warfarin plus clopidogrel plus aspirin. So you had triple therapy. So dual therapy was compared to triple therapy here. When you look at the outcomes of the summary of the results of redual PCI, compared to 110 milligram, which was similar to rivaroxaban in terms of increased thromboembolic events, death or unplanned revascularization, or a thromboembolic events or death or stent thrombosis, was higher with 110 milligram twice daily of dabigatran with clopidogrel versus when you use 150 milligrams of dabigatran along with clopidogrel, there was significantly lesser bleeding, whether it is major, minor, needing attention, or even the ischemic events were also lesser. So definitely it proved superior to existing for the time, that is dual antiplatelet with vitamin K antagonist. So learning from these two trials of Pioneer and Dual, which really challenged the existing thought process of the time, only patients undergoing PCA were included in this trial. The NOAC plus P2Y12 inhibitor appeared to be associated with reduced bleeding versus triple therapy of dual antiplatelet and vitamin K antagonist. Pioneer assessed doses of rivaroxaban not tested for stroke prevention, that is 2.5 milligram twice daily. Due to the design of Redual, it is unclear whether the reduction in bleeding are due to the use of dabigatran or because the avoidance of aspirin. Because here there is no triple therapy using dabigatran. It is only dual, dabigatran and clopidogrel, 110 or 150 milligrams of dabigatran. So it was not clear why the bleeding is less. Either is it because of dabigatran or absence of aspirin. We will realize as we go further. Neither trial powered for efficacy outcomes. In Pioneer, the doses of rivaroxaban were associated with numerical increase in cardiovascular death, stroke and stent thrombosis. In Redual, the lower dose of dabigatran was associated with numerical increase in death, MI, stroke, and stent thrombosis. That is 110 milligram. Only 150 milligrams showed superiority. Coming to the Augustus research hypothesis was set in two independent hypotheses, that is, apixaban is at least non-inferior or superior to vitamin K antagonist on composite outcome of major bleeding or clinically relevant non-major bleeding in patient non-valvular AF who develop ACS or require PCI with concomitant antiplatelet therapy of a P2Y12 inhibitor with or without aspirin. Remember, with or without aspirin. The second hypothesis was single antiplatelet therapy with P2Y12 inhibitor is superior to dual antiplatelet therapy. That is what they wanted to check. Can we drop aspirin with a P2Y12 inhibitor and aspirin on the combined outcomes of major bleeding, CRM bleeding patients with non-valvular AF with recent ACS or requiring PCI with planned concomitant anticoagulation therapy. These two hypotheses, the trial was set. The clopidogrel was the base P2Y12 therapy here, except in 6% where ticagrelor was used. There were two groups. The apixaban group had 5 milligram BID. 2.5 milligram BID was in selected patients, those whose body weight was less than 60 kg, age of more than 80 years, and creatinine of more than 1.5. Otherwise, standard dose of apixaban 5 milligram BID. There were two double-blinded. They were either combined with aspirin or placebo. So either you had a triple therapy or a dual therapy here, you could compare because clopidogrel is standard. The other one had vitamin K antagonist where INR was between 2 to 3 had to be maintained. They were subdivided into two groups, either along with aspirin or placebo. So both are triple therapy and dual therapy was compared, including two different anticoagulation arms. One is apixaban, the other one is vitamin K antagonist. Primary outcomes, ICTH major CRM bleeding. Secondary outcomes were death, hospitalization, death ischemic events. When you look at the baseline characteristics, these are not very, very innocuous patients. When you look at them, the CHADVAS score in mean was about 3.9, so very significant higher risk for stroke. Hasbled score about 2.9, so higher risk of bleeding. Prior oral anticoagulation was seen in 49%. That is about half the patients were receiving. And when you look at the P2Y12 inhibitor, clopidogrel was used in about 92% of the patients. Summary of the outcomes, when you look at the major CRM bleeding, apixaban had significantly lower, 31% lesser chance of relative risk reduction in bleeding, and 4.2% absolute risk reduction in terms of major bleeding when you used apixaban versus warfarin. And when you look at whether you used aspirin or a placebo, that is dual or a triple therapy, if you used a triple therapy including aspirin, the bleeding risk was significantly higher, 89% higher risk of bleeding if you used aspirin versus if you did not use aspirin, if you came down to dual therapy. And when you look at the major bleeding, if you combine clopidogrel, aspirin, and vitamin K, that's the highest bleeding risk, 18.7%. If you have clopidogrel, aspirin, apixaban, second highest bleeding risk of 13.8%. If you just drop the aspirin and you continued only vitamin K and clopidogrel, the risk of bleeding reduced to 10.9% from 18.7% if you just drop aspirin. And the least risk of bleeding was when you combined apixaban with clopidogrel without aspirin, when it was only 7.3%. So when you compare the triple therapy of aspirin, clopidogrel, vitamin K antagonist of 18.7% to apixaban and clopidogrel, when the bleeding became 7.3%, you are reducing the risk of bleeding by absolute risk reduction by 11.4%. Absolute risk reduction, tremendous. Now, when you look at the secondary outcomes of death or ischemic events, it's again important mix you must realize here. You have apixaban, vitamin K, and aspirin. Death ischemic events were 6.7% with apixaban, vitamin K 7.1, and aspirin 6.5% compared to 7.3 with placebo. Death was almost similar, 3.3% apixaban, vitamin K 3.2, with aspirin 3.1, without aspirin 3.4, slightly higher. CV death, 2.5 with apixaban, 2.3 with vitamin K, 2.3 with aspirin, 2.5 with placebo. Stroke, you need to significantly benefit here. You can see stroke was reduced to 0.6 if you used apixaban versus vitamin K 1.1%. There's almost a 50% reduction in stroke. And if you look at the aspirin, there's no great benefit in reducing the risk of stroke at all. So when it comes to stroke, aspirin is useless. Now the role of aspirin comes in. When you look at the myocardial infarction, with apixaban 3.1, vitamin K 3.5, aspirin when you use 2.9%, if you do not use 3.6%. There's a 19% relative risk reduction of MI if you use aspirin versus no aspirin. The chance of definite or probable stent thrombosis is not greatly different. Apixaban 0.6%, vitamin K 0.8. But if you use aspirin and if you do not use aspirin, there's a great difference. There's a 48% reduction of stent thrombosis if you use aspirin versus if you do not use aspirin. So in the acute stage, when there is a stent thrombosis risk, aspirin has beneficial role. When you look at the urgent revascularization, no great difference between apixaban and vitamin K. But when you look at the aspirin, there's a 31% relative risk reduction with aspirin. Hospitalizations are almost similar. So now, when you look at the death and hospitalization, when you compare apixaban versus vitamin K, there's a marginal 17% relative risk reduction with apixaban compared to vitamin K antagonist, definitely better. But look at this. Whether you used aspirin or placebo, there's no difference in death or hospitalization. just 0.08%. When you look at the death and hospitalization, it's the maximum when you use clopidogrel, aspirin, vitamin K at 27%, and it's the least 22% when you use only as apixaban and clopidogrel. So when you use only apixaban and clopidogrel versus triple therapy involving vitamin K antagonist, there's a 5.5% absolute risk reduction. And the number needed to treat is only 18%. If you treat just 18% with clopidogrel and apixaban versus vitamin K antagonist, aspirin, clopidogrel, you need to treat 18% to prevent one hospitalization or a death. Secondary endpoint, death and hospitalization, when you look at the trial, the all-cause hospitalization between vitamin K and apixaban was superior by 17% relative risk reduction. Cardiovascular hospitalization, apixaban reduced by 19% relative risk reduction. Bleeding-related hospitalization, relative risk reduction is 35%. All-cause hospitalization, now when we look at the aspirin, actually aspirin increased by 10%. Cardiovascular hospitalization, almost equal between aspirin and placebo, whether you used it or not. Bleeding-related hospitalization, almost doubled when you used aspirin. 2 times it becomes if you use aspirin versus if you did not. All-cause hospitalization is the maximum when you use aspirin, clopidogrel, vitamin K antagonist, and least when you use apixaban and plus clopidogrel. Cardiovascular hospitalization, story is the same. Bleeding-related hospitalization, absolute, this story is the same. Highest with aspirin, clopidogrel, vitamin K antagonist, least with apixaban and clopidogrel. Now, this is about the safety, and now let's come to the efficacy. This is a very touchy situation for most of the cardiologists because you're committing by doing a PCI and you're very sensitive about stent thrombosis because mortality is high. When you look at the ischemic outcomes, whether we used apixaban or vitamin K, death or ischemic events not greatly different, 6.7 versus 7.1. Death was 3.3 versus 3.2. CV death 2.5 versus 2.3. No great difference. But look at the stroke. Stroke is reduced by 50%, close to 50%. Great benefit. Myocardial infarction, no great difference. Definite or stent, probable stent thrombosis, 0.6 to 0.8, less than 1%, almost the same. Urgent revascularization, almost the same, less than 2%, 1.7 and 1.9. But when you look at the hospitalization, there's a 17% relative risk reduction. So ischemic events, when you look at the definite or probable stent thrombosis, it's significantly reduced when you use aspirin. So aspirin greatly benefits only in terms of reducing stent thrombosis by close to 48%. And when you look at the rate of stent thrombosis at 6 months, it is definite stent thrombosis is 0.6% and probable or definite together is less than 1%. So it's a very small percentage. When you look at the definite probable stent thrombosis according to antithrombotic regimen, you have the least chance of stent thrombosis when you use apixaban, aspirin, and clopidogrel. The risk is about 0.5 to 0.6%, but the bleeding is slightly higher. But instead of that, if you just use apixaban and clopidogrel, the risk becomes between 0.8 to 1.9%. That is still less than 1%. The risk of stent thrombosis is highest when you use vitamin K antagonist and clopidogrel without aspirin. So this is the cocktail. So if somebody is at highest risk of stent thrombosis, you can use apixaban, aspirin, and clopidogrel. If they have high risk of bleeding, then just use apixaban and clopidogrel to have the least bleeding. So Augustus bleeding event versus stent thrombosis to look at the net clinical benefit. The major bleeding when you use aspirin, with aspirin is 367, without aspirin is 204. So just 9% without aspirin, 16.1 with aspirin. When you look at the definite of stent thrombosis, 0.63 when you use an aspirin and 1.08 when you do not use. So bleeding events are much more common than stent thrombosis events in Augustus. When you look at the number needed to treat at 6 months to benefit, it's about 222 patients, and number needed to harm at 6 months were just 41 patients. For 6 months, if you continue triple therapy, if you treat 41, one would be harmed with a major bleeding. But on the contrary, when you look at just the end of 1 month, what I told you about the 6 months. Now coming back to it, 1 month, number needed to treat to get the benefit is just 176, and number needed to harm at 1 month is 100 more patients. So the major bleeding is going to be, and net clinical benefit is going to be maximum in the first 30 days if you use triple therapy, means if you use aspirin versus if you do not use aspirin. So till what time period does removal of aspirin influence ischemic events? When you look at the ischemic events with placebo versus aspirin, there is benefit in terms of stent thrombosis, 50% reduction, myocardial infarction is reduced, and urgent revascularization is slightly reduced. So analysis of the stent thrombosis events suggested that most of the increased risk was early within 30 days of randomization. If you see this graph, the blue one is the stent thrombosis, and it progressively drops off beyond 30 days. But the bleeding is a constant and a long-term problem that exists. So the crossover point is probably at 30 days. Look at this graph very, very clearly. Severe bleeding and ischemic outcomes randomization at 30 days. This is at 30 days. The fatal intracranial hemorrhage, major bleeding, when you look at them with aspirin and placebo, it progressively increases from 0 to 30 days, progressively increases. CV death, stroke, MI, stent thrombosis, all these are ischemic events. They also increase from 0 to 30 days, progressively wider. Now, look at the major bleeding risk and ischemic event risks between 30 days to 6 months. The bleeding risk progressively increased between 30 days to 180 days. But when you look at the CV death, stroke, MI, and stent thrombosis with ischemic events, there is almost constancy. There's no great difference whether you give aspirin as an add-on or you remove and leave them on a placebo. So there's no increased risk of CV death, stroke, MI, stent, and thrombosis between 30 days to 180 days. So this clearly tells us that I think this is the tipping point where you must withdraw aspirin and reduce the risk of bleeding, and without a significant risk of increasing the ischemic events. So concluding, among patients with atrial fibrillation and recent PCI, including current generation of drug-eluting stents, definite or probable stent thrombosis is rare, occurs more frequently early after angioplasty, probably within 30 days. These data support the use of apixaban and a P2Y12 inhibitor without aspirin during the first 6 months for most patients, considering the almost twofold increase in the bleeding when you add aspirin to this within the first 6 months. In patients with a high risk of stent thrombosis and an acceptable risk of bleeding, using aspirin up to 30 days, you can stop at the end of first day, 1 week, or 30 days, depending on the bleeding risk, but up to 30 days after PCI should be considered. Further studies to identify patients who might have benefit from most from this strategy is warranted. Finding the antithrombotic sweet spot, that is, risk of ischemic events have to be balanced equally against risk of bleeding events. And that sweet spot depends on the clinical context, whether it is renal failure patients, geriatric, he's got acute ACS, non-ACS, what kind of intervention, then patient PCI characteristics, antithrombotic mix, the dose and the duration. And the guidelines now clearly tell us that today, 2020 ESC AF guidelines for AF and ACS PCI, if somebody is on VKA or a NOAC, at presentation, if the INR is less than 2.5, you can give heparin and then do a PCI with aspirin, clopidogrel, and a NOAC. Can be started from the day of PCI onwards till about a month, less than a week or a month. You should keep looking at, can we drop the aspirin and leave them on a NOAC and a P2Y12 inhibitor for next 12 months. And after 12 months, it's going to be just NOAC. If fibrinolysis is to be considered only if an oral anticoagulation is below therapeutic reference range, that is less than 2, only then consider. And if a patient is subjected only to medical therapy, do not add aspirin. You're going to leave the patient on NOAC and a P2Y12 inhibitor. If patient is on a vitamin K and a NOAC, chronic coronary syndrome, if the INR is between 2 to 2.5, you can perform a PCI on heparin and P2Y12 inhibitor along with an aspirin, probably for a day or two or a week, or try to withdraw it as quickly as possible if the ischemic risk is low, and leave the patient only on NOAC and P2Y12 inhibitor. That's the current strategy. Thank you. Am I audible?
Yes, sir, you are audible.
Thank you. Dr. Said, I think you are on mute. Can you unmute yourself, please?
Yeah, Dr. Girish, it's a very wonderful explanation regarding the entire strategy of the management of atrial fibrillation in various aspects. Medical management versus with a PCI or elective PCI. I think that the entire thing has been fully covered. Especially, we are basically focusing on the Augustus trial, which is the most benefitful trial. I have one question in that. In the patients of atrial fibrillation, which can be triggered by coronary artery disease, or those who are having a paroxysmal atrial fibrillation, in such a patient, what is your recommendation? Whether it should be use a fixed band or any other NOAC?
I think if it's a proximal, persistent, or a permanent atrial fibrillation, there's no difference. You stick to the same, because the risk of the stroke is significantly higher even if it's a paroxysmal atrial fibrillation. Unless you have documented that it was just one episode and it has never recurred, then you can treat them as, in an acute situation there was, and then it has never occurred, then you could go back to dual antiplatelet. But even a paroxysmal atrial fibrillation, therapy is the same, like the Augustus trial.
Thank you. Any other question from the floor? Dr. Gaurav?
Dr. Gaurav, are you there?
Network seems to be freezed.
Yeah.
Thank you, Dr. Girish. Any other questions from the floor?
In the chat box, I don't see much in the chat box.
We don't have anything, sir. We don't have any questions.
Thank you, Dr. Syed.
Thank you very much. Thank you very much.
Thank you, Dr. Syed, as well as Dr. Gaurav for chairing the session. Meanwhile, it is our duty to thank our last speaker of the day, Dr. Nasudi sir. Thank you for joining with us. So that completes the scientific session, the virtual part. As there is a saying, all the good things also should come to an end. Here we are at the final leg of this e-spectrum virtual mode. Hope you all had a very good scientific session, as well as we believe that you all have visited our trade exhibition area as well. Before I hand over to Dr. Purushottam, there is a small announcement. All the participants, those who are logged in online, you can go to the lobby area for a certificate. You can give your feedback and download your e-certificates. Now, I'll hand over to Dr. Purushottam, Organizing Secretary, e-Spectrum 2022, for his vote of thanks. Over to you, sir.
Dear friends and colleagues, we are into the concluding part of the session, the hybrid session. And another year goes by, and another edition of Spectrum also thus comes to an end, 11th edition to be precise. It's been a constant endeavor to deliver the very best in cardiology and the latest in interventional cardiology every year. And just wanted to make sure that everybody goes on this time also a lot wiser with a few take-home messages. So at the outset, I'd like to place on record our sincere thanks and appreciation to all those who made it to today's session, both physically and virtually. And we do appreciate the fact that you all found value in our cardiology update, and you also felt that it's worth spending your precious Sunday with us today. So thank you very much. I also take this opportunity to thank all the speakers, moderators, and my fellow panelists for your esteemed presence. Our event manager tells me that today's session recorded a attendance of more than 300 delegates, both physically and virtually, and that's quite a proud figure, honestly. Third, the scientific updates such as these will not be possible without the generous support by friends from pharma and industry, and we sincerely thank each one of you who made this event possible. Our patrons, the management of AJ Hospital and Research Center, AJ Institute of Medical Sciences, they're a source of constant support and inspiration. We take this opportunity to thank them profusely. Lastly, our thanks and appreciation also must go to the event managers of today, A1 Logistics. Thank you very much for your technical support. So, ladies and gentlemen, it's curtain for Spectrum 2022. Wishing you all a wonderful new year. And until we see you again in 2023, good luck and goodbye.
Friends, we have a quick lunch break. After that,